All right. So welcome everybody to the Policy Impacts Inaugural Conference. Just by way of background, we formed Policy Impacts because we were looking to promote standardization and evaluations of policy effectiveness. And in particular, our organization focuses on the use of the marginal value of public funds framework. Our goal is to assist researchers conducting empirical welfare analysis to help practitioners and the general public better understand and compare the long-term costs and benefits of a wide range of public policies, and to support government decision-making by promoting rigorous program and policy evaluation through the MVPF framework. Today, we're delighted to have presentations on 6 wonderful academic papers that study a broad range of public policies, from healthcare expansions to education subsidies. These papers not only provide important causal estimates of the impacts of those policies, but the presenters have also been thinking seriously about how to translate their findings into their implied marginal value of public funds of those policies. And so this allows us to step back and compare each of these policies on a similar normative playing field. Today at Policy Impacts, this marks our first conference, and we hope this is the first of many. In the coming months, we'll be posting a call for papers for next year's conference. We hope to feature the work of many researchers in the audience today. We should also note that a core mission of Policy Impacts is the construction and maintenance of the Policy Impacts Library that is available at policyimpacts.org. This library provides a comprehensive database of MVPF estimates from rigorous policy evaluations like the ones you'll hear about today. Building this library is really a collaborative effort. So to all the researchers in the audience, if you're currently studying a policy and believe that your estimates could be translated into their implied MVPF, please do get in touch with us. We're delighted to provide technical support and add your work to the library. We'll also take the time at the end of the conference to discuss our Early Career Scholars Grant, which is a funding opportunity available to untenured researchers and graduate students who are interested in constructing MVPFs in their own work. Now, before I turn this over to the presenters, I do want to take a moment and thank those who have worked really hard to make this conference happen, most notably Liz Tock and Otto Klammer. Thanks to you for handling so many of the logistics along the way and letting us be here today. A note on process, throughout the presentations, you can submit all your questions through the Q&A box. I will be moderating and will be interrupt the speakers with any important clarifying questions along the way. But we'll also have some time at the end of each talk to have a more kind of in-depth response to the questions raised. And I'll either repeat your question directly, or if it's a bit more involved, I might call on you to unmute yourself and deliver your question. Okay, so without further ado, I want to turn it over to Elisa Jácome. Elisa is currently a postdoc at Stanford and will soon be joining the economics department at Northwestern. She'll be presenting her work, Mental Health and Criminal Involvement, Evidence from Losing Medicaid Eligibility. So take it away, Elisa.
Okay, wonderful. So thank you so much. My name is Elisa Jácome, and as Nathan said, I'm a postdoc at Stanford. I just want to take a minute to say thank you to Nathan, Ben, and everybody else at Policy Impacts for putting together this conference and for inviting me to speak. I'm very humbled to be here. So as I mentioned, I'll be presenting this paper about mental health and criminal involvement. And the main motivation for this paper is the high prevalence of mental illness in today's criminal justice population. So to illustrate this prevalence, I'm showing you a figure I made here with my primary data source. I'll tell you a lot more about the data later on, but I simply want to show you the likelihood of incarceration for individuals with and without mental health histories in a sample of low-income men from South Carolina. So here, the blue line shows you the cumulative likelihood of incarceration for individuals who had a mental health diagnosis by age 17. And this orange line shows you the same likelihood of incarceration for those that never received a diagnosis. So you see that by age 24, low-income men with mental health histories, they're 3 times more likely to be incarcerated than men without mental health histories. And this very strong correlation between mental illness and crime is not just present in my data, but it's well established in other data sources as well. And from a public finance perspective, individuals with mental illness tend to have higher recidivism rates, longer prison sentences, and more expensive medical needs. So they're a relatively high cost group within an already expensive criminal justice system. All of this raises the natural question of whether this correlation will tend to persist, or whether improving access to health services and mental health care in particular could potentially reduce the likelihood that these individuals come into contact with the criminal justice system. And so that's exactly the question that I ask in this paper. And the way that I will study this question is by using this administrative data from South Carolina that links individual level records across a number of government agencies. And so that's going to make it possible for me not only to see the same person across data sets, but also over time. And this data set is relatively unique in that it includes both health and crime-related outcomes. So importantly, I have access to Medicaid claims data, which allow me to identify men with diagnosed mental illness. And I also have data from 3 law enforcement agencies that helps me see all contact that these men have with the criminal justice system. So data like this is more common in other countries, in particular in Scandinavian countries, but it's much more rare in the context of US administrative data. And the way that I will study this question and think about the effect of healthcare on these individuals' criminal involvement is by leveraging a break in Medicaid coverage that occurs when individuals turn 19 years of age in South Carolina and age out of their Medicaid eligibility. And I just want to take a second to note that Medicaid is a very relevant program for this group, not only because it provides access to insurance for many of low-income populations in the US, but it is also the largest payer of behavioral health services in the US. So it's quite an important program for thinking about mental health care. So let me pause now in case there's any clarifying questions. Otherwise, let me tell you a little bit more background and also more about the data. Okay. Wonderful. So just so that we're all on the same page, let me take a second to talk about why it might be the case that losing access to insurance might affect an individual's criminal behavior. So one potential channel that might come to mind is the straightforward income effect, this idea that if individuals have access to Medicaid, which is free, once they lose access to those services, then they might face higher expected medical costs, and this might increase their likelihood of committing economically motivated crimes. But another possibility, another channel that might be underlying this relationship, as you can, which is what I have in mind, as you can imagine, is this mental health channel. This idea that losing access to insurance might mean losing access to mental health treatment or medications or resources. And so why might that affect an individual's criminal propensity? So first, if an individual is relying on Medicaid for access to these medications or services and they lose access to them, then they might be more prone to making errors in judgment or decision-making afterwards, including decisions related to criminal behavior. Another possibility is that these individuals, if they're relying on Medicaid for access to medications, might be more likely to self-medicate with illegal drugs and therefore more likely to be arrested or incarcerated for these types of offenses. And finally, another possibility is that losing access to these services might disrupt individuals' human capital formation or their labor market productivity, and that might make criminal activities more attractive in itself. So you can think of losing access to these services as perhaps making it more difficult to find a job or to keep a job. Okay, now let me tell you a little bit more about the setting of the paper. So for those of you that are less familiar with the state of South Carolina, it's a state with around 5 million residents, similar to the country of Denmark. And it's a relatively low income state with low levels of health insurance coverage among adults. So I've included some statistics here to give you a sense. We see that South Carolina has a lower median household income and a higher poverty rate than other states in the country. Almost a third of its residents are Black. And among adults ages 19 to 25, a larger share of them are uninsured relative to young adults in other states. And so I'm going to be using administrative data from South Carolina in order to study this question. And as I mentioned, one of the key components that I have in the data is access to the Medicaid insurance claims, which not only allow me to see information about all visits to doctors, hospitals, as well as all pharmacy claims, but it also allows me to see data on when individuals are enrolled, what diagnoses they're receiving, and the services that they're using. And then importantly, this data is linked to data from law enforcement divisions, and this is going to allow me to see information about all arrests, prison spells, as well as juvenile justice detentions. And finally, I also have data from other data sources, which I implement throughout the paper, but are a little less relevant for this particular question, but I also have information about participation in public assistance programs, educational records, and so on. And in terms of the sample that I'm looking at, this is going to be a disproportionately low income sample of adolescents in South Carolina. So to be in the sample, an individual needs to have attended one of the poorest high schools in the state, as measured by the share of students in a high school that are receiving free or reduced price lunch. So you can think of the sample of individuals as representing the residents of the poorest half of neighborhoods in the state. And so putting all of this data together, I'm able to construct a panel data set of children starting at age 10 And I've included some statistics here to give you a sense of who these individuals are and their participation in certain programs and so on. So we see that 60% of these individuals are Black. 3/4 of them have ever been enrolled in Medicaid throughout adolescence or in the SNAP program. And contact with the criminal justice system is relatively high, even at a young age. 20% of them at some point have been referred to the Department of Juvenile Justice. And in terms, and I also want to show you the likelihood or the prevalence of mental illness in the sample, just to give you a sense of what we see in the Medicaid insurance claims data. And what I can tell you is that the prevalence is relatively high. So among boys who are enrolled in Medicaid throughout adolescence, slightly over half of them at some point have been diagnosed with a mental disorder. So I've included here the 5 most common diagnoses that I see in the data. And the most common diagnosis is hyperkinetic syndrome, otherwise known as ADHD. But I also see a sizable group of individuals with other diagnoses like developmental delay or conduct or emotional disorders. And I also want to give you a sense of the types of behavioral services that these behavioral health services that these individuals are using. And the 2 most common services are case management services, which you can think of as being meetings with social workers or counselors, as well as psychotropic drugs, or in other words, mental health medications, which I can see through the pharmacy claims. So now let me tell you about how I go about thinking about this loss in Medicaid and how it affects these individuals' criminal involvement. So for a bit of background, in South Carolina, low-income children ages 0 to 18 are eligible for public health insurance through the Medicaid program, but then they age out of this eligibility when they turn 19. And so even if you've been using services throughout adolescence, most individuals will lose access to these services upon reaching 19 years of age. There are certain exceptions, for example, individuals with disabilities or children that were formerly in foster care, but by and large, childless adults in South Carolina have very limited access to Medicaid services starting at 19. And so I'm going to leverage this loss in Medicaid coverage in order to estimate its effect on men's likelihood of incarceration. And as you can imagine, given these institutional features, there are numerous ways that I could have gone about estimating this effect. In our main approach, which I will now explain in more detail, I'm going to compare individuals who were enrolled in Medicaid right before age 19 and who lose access. I'm going to compare them to similar individuals. You can think of them as their classmates or their peers who were enrolled in Medicaid earlier in adolescence, but not right before age 19. So they're less affected by this termination in coverage. And this will be my baseline comparison group. But in the paper, I also explore alternative comparison groups. For example, these individuals who are allowed to stay on Medicaid past age 19. And I do a number of other checks and placebo tests in order to see whether any effects that I'm finding are really driven by this loss of services at 19. In all of these approaches, I find very consistent results. So given time limitations today, I'm just going to focus on my baseline preferred research design, which I'll now tell you more about. So the empirical approach is going to be a difference in difference design in which I look at individuals that are likely to be enrolled in Medicaid at age 19 and think of that as the treated individuals defined by their enrollment in Medicaid between the ages of 16 and a half to 17 and a half. And then because everybody's losing access to Medicaid at the same point in the life cycle, I'm going to use a comparison group of individuals that were less likely to be enrolled in Medicaid in order to account for age trends in crime. And so who are these individuals? They are similar individuals who were enrolled earlier in adolescence, but not between the 16 and a half to 17 and a half period. And you might be wondering why it is the case that you can be enrolled earlier, but not later in adolescence. And so let me take a minute to talk about that. So some of these individuals, they might be eligible in terms of their family income, but not be actively enrolled in the Medicaid program. And in the time period that I'm studying, that was actually quite common in the state of South Carolina for individuals to be eligible but not enrolled. And this occurs because enrolling in Medicaid is an active choice that families have to make every year. And so families might be deterred by the hurdles to enrolling, for example, long waits at the county office or needing wage information from their employers. Or another possibility might be that they have decided that they no longer want or need Medicaid services in this time period. Perhaps they're in a moment where they're feeling relatively healthier and don't want to enroll. And so I cannot, unfortunately, discern exactly in the data why these individuals are not enrolled, but I will use a comparison group of individuals that's attending the same schools, that are born in the same years, and so on, as this comparison group of individuals. And so to give you a sense of the empirical approach, to summarize a lot of what I've just said, I will assign these individuals into the two groups between ages 16 and a half to 17 and a half. And then I will follow the two groups for a full year and a half before age 19 in order to see whether their likelihood of incarceration and their overall criminal propensity seem to be similar. So then if I begin to see changes or divergences in outcomes that start right at age 19, I can attribute those differences to the loss in Medicaid coverage that one of the groups is experiencing in a salient way. And the main outcome of interest that I'm going to look at here is the likelihood of incarceration, whether that's in state prison or in a local jail. And this is going to combine data from two of the data sources that I have. And the identifying assumption, which is standard in the difference in differences framework here, is going to be that the treated individuals would have trended similarly to the comparison group in the absence of the Medicaid loss. So as I mentioned, it'll be important for me to show you that these two groups look similar in terms of their criminal propensity prior to age 19, so that if they begin to diverge at 19, I can attribute that to the Medicaid loss. And I also do want to highlight that in terms of losing access to Medicaid at 19, that's quite unique to the Medicaid program. Most of the other changes that happen in the transition between childhood and adulthood typically happen earlier in adolescence. For example, individuals are allowed to drop out of high school at age 17, you age out of foster care at age 18. And so 19 is quite particular in terms of being the time that you lose access to Medicaid services. Here, I'm just showing you to confirm that one of the two groups did indeed face this large decline in Medicaid enrollment. So this is just the raw means in the data showing that the way that I've constructed the two groups, this treated group here in red, around 80% of them are enrolled before age 19. And then you see this large decline in enrollment that happens when they turn 19. And so the specification that I'm going to run in order to look at the effect of this Medicaid coverage loss on the likelihood of incarceration is a standard difference in difference estimation, in which I will look at the differences between the treatment and the comparison group for 6 quarters in the pre-period, and then for 8 quarters in the post-period. And this beta tau coefficient will represent the differences between the two groups in any quarter tau. And I'm going to look at two main outcomes. The first is whether an individual is incarcerated in any quarter tau. And then I'm also going to look at the cumulative analog of this outcome, whether an individual has ever been incarcerated. And one of the reasons that I like this latter outcome is that if we do in fact see an increase in incarceration, this latter outcome allows us to see whether it's from the same individuals recidivating or whether it's from individuals that had not been incarcerated before coming into serious contact with the criminal justice system for the first time. So now let me give you a sense of the results that I find. So on the left-hand side here, I'm showing you just the raw means of the data. And on the right-hand side, I'm plotting the difference in difference estimates from the specification I just showed you. And you see that the two groups look relatively similar in terms of their likelihood of incarceration before age 19. And then you see this divergence in outcome that occurs afterwards, so that treated individuals who lost access to Medicaid are 15% more likely to be incarcerated in any given quarter after 19. And when we look at the cumulative version of that, we see that this increase is coming from new individuals being incarcerated, individuals that had not experienced incarceration before. So back of the envelope calculation suggests that 10% fewer men in these cohorts would have been incarcerated by age 21 if the Medicaid eligibility had not lapsed. And so the question here, I've shown you all of these individuals who lost access to Medicaid. One of the questions that arises is this coming from losing access to health insurance broadly, or is this about losing access to mental health care? And so the way that I look at that question is by running a very similar specification, but this time looking at a triple difference specification in which I'll look at the treatment comparison differences for individuals with no mental health history. And then I will see whether the treatment effects seem to differ for individuals with mental health histories to see whether there's any difference between these groups. And so when I do that, I see here again with the raw means on the left-hand side that individuals in blue are those with mental health histories and individuals in orange are those without. Those individuals without mental health histories, despite losing access to Medicaid, they continue trending similarly to their comparison group after age 19, whereas this increase in incarceration seems to be entirely driven by the men with mental health histories. And we see a very similar picture once we look at the cumulative analog. This increase in incarceration of new individuals seems to be coming entirely from treated men with mental health histories having their first incarceration. So that by age 21, they're 3 percentage points or 22% more likely to have ever been incarcerated. I'm not going to go too into detail on the other results of the paper, but I'm happy to talk more about them at the end, or feel free to look at the paper. But I did want to mention that I used the detailed information in the incarceration records as well as the insurance claims in order to understand whether there's changes in any specific type of offense that's driving these results, or whether there's any specific group that seems to have a more pronounced effect. And what I can tell you is that I find increases in violent, property, and drug-related offenses. So it seems to be the case that losing access to these health services impacts all types of criminal involvement, and there's not necessarily one specific channel through which it manifests. And then the other checks that I do to see whether if this was really about losing access to behavioral health services, then we would expect the individuals that were using these behavioral health services right before age 19 to be more affected than the individuals with mental health histories as well, but that were not using these services. And so I divide the treated men with mental health histories along this dimension. And when I do that, you see that the treatment effect for those that were using services more recently is more pronounced, and they are more likely to be incarcerated in the post period. Specifically, they're more likely to commit property crimes, suggesting that perhaps there's an economic motive to these offenses. And similarly, I think about whether certain individuals that are relying on Medicaid for access to medications in particular, whether they are more likely to have a pronounced effect. And I find a very similar picture in that men who were relying on Medicaid for access to these mental health medications are more likely to be incarcerated in the post period. Again, they're more likely to commit property, but also violent offenses. And so, okay, so with my remaining time, I want to talk about putting these causal estimates into context and constructing the marginal value of public funds estimate, which is why we're all here today. And since I'm the first presenter of the day, I do want to take a minute just so that we're on the same page on how to calculate the marginal value of public funds. And so the MVPF is defined simply as the ratio of the benefits of a policy relative to its costs. And so the numerator, or the willingness to pay, is going to reflect the extent to which the policy improves the lives of the beneficiaries. And the denominator is going to be the net cost to the government. So this is not only going to include the short-term costs of the policy itself, but it will also include any long-term effects that the policy might have on a government's budget. And so given my results and the topic of my paper, the policy that I'm considering is extending Medicaid eligibility for 2 years and thinking about what that policy gets us in terms of benefits and comparing that to its costs. And both in the upcoming slides as well as in the paper, I calculate both upper and lower bounds of this MVPF ratio under a variety of assumptions. So now let me tell you a little bit more about how I think about the numerator, or the benefits of this policy given the context. So the first component that I think about is the benefit in terms of having fewer criminal victimizations. So the results of the paper suggest that if Medicaid eligibility had not lapsed, then fewer crimes would have been committed, and crimes are quite costly for the individuals that experience them. And so I begin by using the estimates and thinking about what was the excess number of arrests that occurred because of this lapse in Medicaid eligibility. And then, because not all incidents, criminal offenses end in arrest, I use arrest to victimization ratios from the literature to calculate the number of excess criminal offenses more broadly. I then combine these numbers with estimates from the criminology literature of the average cost of violent, property, and drug-related offenses in order to calculate the total cost of having these fewer criminal victimizations. And then finally, I also think about victim costs from potential recidivism. So if individuals are more likely to be incarcerated, we know that there's also a high likelihood that they will recidivate, and those offenses would also then impose victim costs. And so I think about, if we are able to reduce the number of individuals who are incarcerated at younger ages, what would that buy us in terms of benefits from lower recidivism? The second component that I think about is improved labor market prospects. And so the idea here is that individuals, when they're incarcerated, they forego their earnings for the time in which they're incarcerated. And so I think about this foregone income and look at census data in order to calculate how much income was foregone during the incarceration spell. I also think about the fact that prior research has shown that incarceration can reduce the employment rates as well as the earnings of formerly incarcerated individuals in the years after they're released. And so in some of the calculations, I also include the losses in income that follow the incarceration spell. And then finally, I think about the value of the public insurance transfer. So in other words, how much do the beneficiaries who get this Medicaid eligibility, how much do they value the health insurance that they're getting? And finally, and I won't go too much into detail on this because Amy's presenting right after me exactly on this topic, but one of the last components that will enter the numerator is thinking about who bears the economic incidence of these Medicaid transfers. And so if it's individuals, low income or otherwise, then that component enters into the numerator as well. And then now let me tell you about the denominator, which is the net cost to the government. So not surprisingly, one of the main costs to the governments is the cost of expanding Medicaid eligibility. And so I think about the take-up of the program based on the enrollment patterns that I see in my data, and I use annual per enrollee Medicaid costs in order to think about what would the total cost of expanding Medicaid eligibility be for these 19 and 20-year-olds. And then I also, back to my earlier comment, this number will be dependent on whether the government bears the economic incidence of the Medicaid transfer. So again, in constructing these ratios, I think about different assumptions of who might bear the incidence of these transfers and take that into consideration. The second component of the denominator in terms of thinking about the net cost of the government of this policy is the reduced fiscal costs from fewer incarcerations. So what you can think of here is that if we expand health insurance and fewer individuals are incarcerated, then the government will be less likely to spend money in the criminal justice system for these individuals. And so I use the average sentence served by offense type, as well as the cost of incarcerating individuals in order to account for this reduced fiscal cost. Nathan, did you want to ask a question?
No, I accidentally hit the raise a hand. Okay. But I guess, why don't you keep going and I'll pause. There's a question in the Q&A and there's another question that we'll ask once you're through.
Okay, wonderful. So let me just talk about the last component of the denominator, which is this increase in tax revenue. So as I mentioned before, in the numerator, we think about, well, maybe these individuals that would have otherwise been incarcerated, now they'll have improved labor market prospects, and better labor market prospects for individuals translates to higher tax revenue for the government. And so I use my earlier calculations about foregone income and the income losses that follow incarceration in order to think about what would the tax revenue that would be recouped by the government be from this policy. So now I've told you about the components in the numerator and the components in the denominator, and now we can all put it together in order to get this ratio of the marginal value of public funds. And so like I said, I construct upper bounds and lower bounds under different assumptions. So in my most conservative estimate, in which I understate the benefits and overstate the costs, I find a ratio of 1.2. In my least conservative estimate, where I overstate the benefits and understate the costs, I can get a ratio as high as 15.6. But my preferred ratio, which takes a moderately conservative approach, will end up yielding a ratio of 1.9. And just to note that the reason that these ratios can take such a wide range is because they are sensitive both to the cost of crime and how we think about the cost of these criminal victimizations, and also to assumptions about which parties bear the economic incidence of uncompensated care or of these Medicaid transfers. And so what does that ratio of 1.9 mean? This preferred estimate means that the beneficiaries receive nearly $2 in benefits for every dollar that the government spends on this policy. And so you'll see many more MVPF ratios by my fellow panelists, but just to give you a sense of how it compares to the MVPFs of other policies, this 1.9 ratio falls somewhere between the MVPFs for policies that target children, which are roughly tend to exceed 5, and those that target adults, which tend to be closer to 1. And finally, I do want to mention that this calculation does not incorporate other certain components that, if anything, would raise the marginal value of public funds. And I largely don't include them because of data limitations, but just something to think about. One component that might be important is the willingness to pay of individuals to avoid incarceration altogether, be above and beyond any changes in the income they experience. So if there is a value to not being incarcerated, that would enter the willingness to pay as well. Another thing to have in mind is the willingness to pay for improvements in health. And so if individuals experience better health or mental health, and this potentially translates into improved labor market prospects or human capital formation, then that would enter the numerator as well. And then finally, I haven't included this here, but another component that might enter the denominator is the idea that incarcerated individuals, being incarcerated increases the likelihood of relying on public assistance. So to the extent that perhaps this policy would reduce individuals' reliance on public assistance, then that reduced cost would also factor into the denominator. So let me just wrap up and then I'd be happy to take any questions. So in this paper, I estimate the impact of losing Medicaid eligibility on these low-income men's likelihood of incarceration using this unique administrative data set from South Carolina. And I find that men with mental health histories who lose access to Medicaid, they're more likely to be incarcerated in the 2 years following this loss in Medicaid eligibility. And I find that the effects are more pronounced for those individuals relying on Medicaid for behavioral health services and medications in particular. And so putting the causal estimates into context and extending our understanding of these estimates into the marginal value of public funds ratio suggests that this is a cost-effective policy and that it yields more benefits to its beneficiaries relative to the cost of the government with an MVPF ratio of 2. Okay, so I'll pause there, but thanks so much.
Wonderful. So thank you, Elisa. So we have one question in the Q&A box that I'll go ahead and ask. And I'll also just say to those in the audience, feel free to post your questions. So Rafael Poenka asks, kind of stepping back from the initial correlation that you provided at the outset, just think about the relationship correlationally between mental health and incarceration and the different causal pathways that could be driving those different directions. You know, your paper is providing kind of a novel connection going from kind of mental health to incarceration. He's asking if you've thought about kind of what fraction of the correlation, in a sense, can be explained perhaps by your estimates and kind of how much of a cycle we should think of which direction those causal arrows go. But I don't know if you have thoughts that you want to respond to on that point.
Yeah, no, that's a great question. And actually, I can think more about that exactly in how much. So let me take a step back and just give you some sense of how prevalent mental illness is in the criminal justice population. So I showed you that graph in the beginning, but another question might be, looking at all individuals who are incarcerated, what share of them have a previously diagnosed mental illness? So in the data that I see of individuals who've been incarcerated by age 24, 80% of them at some point in adolescence had a diagnosed mental illness. And so the correlation is really quite high. And I think the question becomes, well, is providing mental health care sufficient sort of to break that correlation? And to some extent, my paper's results are showing that at least for some group of individuals who seem to be benefiting from the access to services that Medicaid provides, whether it's the medications in itself, or perhaps it's a combination of medications as well as case management services, for certain groups of individuals, access to this mental health care is quite important. But I think more broadly, we still have a lot to learn about the provision of mental health care, both in Medicaid and more broadly, and understanding who benefits from that and what services seem to be the most important. And so that's a great question and definitely something that I'll continue to think about, but hopefully that gives you a sense of how prevalent mental illness is in the incarcerated population.
Wonderful. All right, a couple more questions in the chat here from Isabel Sahel asks what the assumption is for kind of how long you would have to expand kind of the Medicaid access in order to get the effects that you're seeing. And I think then kind of a related question that I'll throw on top of that is kind of how long you're forecasting the estimates kind of going forward, sort of how you're thinking about time windows, both on the length of the policy under consideration and under the window under which we're thinking about getting benefits.
Yeah, so that's a really great question that I've been thinking a lot about. So right now in this presentation, I just showed you what would we get from expanding Medicaid for 2 years. And I think one of the very natural questions is, well, if you push Medicaid for 2 more years, does that mean that all of those crimes will now not occur? Or does it mean that for 2 years, those crimes won't occur and then they'll just resurface at 21? And so that's a question that I've been thinking a lot about. And one of my I guess one of the things that I do want to note is that this loss in Medicaid eligibility that happens at 19 is very much at the peak of the age crime profile, when individuals are very likely to commit crimes. So to the extent that we think that we can provide these services at age 19 or 20, when these individuals are more likely to have contact with the criminal justice system, then the likelihood of committing those crimes later on, just by the fact that older individuals are less likely to commit crimes, it'll reduce the number of victimizations. But right now I showed you 2 years. In the paper, I'm also considering a longer extension of, well, what would happen if we extended Medicaid services, for example, through age 25 or through age 30, in which we know that for example, especially for men, the brain develops until age 25, and the likelihood of incarceration really drops after that point, and especially for older individuals seems to be quite a bit lower. And so if we can prevent that first contact with the criminal justice system, perhaps by 25, then maybe that's another policy that's worth considering and one that I'm working on. So when I have those estimates, I will also send them to the library.
That's awesome. And just the last half of Isabel's question is maybe more of a point in some sense of thinking about a policy that is delinking the income attachment. So to what extent is that same hump shape of crime kind of around the age of 19 also there for people of perhaps slightly higher income for which there might be a high benefit as well? But
yeah, that's a great question. So I've really focused on this low-income population in this paper, and they tend to be the individuals that have high contact with the criminal justice system, especially these individuals in lower income neighborhoods. But that age crime profile is present, I think, for all income groups. And so to the extent that we think that the provision of these services benefits individuals who are higher income as well, then I did not factor that into my calculations in the presentation today, but my sense is that there would be a lot to be gained. It just wouldn't necessarily come from an incarceration only channel, but it could come through other channels like human capital formation, perhaps the likelihood of attending higher education would be higher, and so on.
Awesome. So I see Hilary and David's hands are raised here as well. I don't know if Hilary, you'd like to ask yours and then David.
I think David was first, but I had a quick question. So I wondered whether you looked at mortality, whether you had access to mortality data from the state, and whether or not you found anything there, because that could also have a big impact for the marginal value public funds.
Yeah, so I actually towards relatively recently have been able to receive mortality data, because that was a similar question, especially when thinking about the reliance on medication and thinking about whether perhaps some of this is related to withdrawal of medications or turning to illegal drugs. That's definitely something that I will be working on and looking at. Is a little tough because the mortality estimates so far that I found are noisy, but it's definitely something that I once I have a better estimates, will also incorporate into this ratio. Thank you.
Just called Finkelstein. I was wondering, and I see Raphael is actually asking a related question in the chat. How are you thinking about the disutility to the people who are, lose access to mental health care, the suffering that goes along with that, and then the, the not so great pleasure of being incarcerated, more than just income loss? Is that you just didn't want to factor that in because that would so stack the deck? Or, it seems like quite first order.
Yeah, I completely agree with you in that. And that's why I did find it important to mention, sort of after showing you the ratios, that at least for me, I didn't want to rely necessarily on estimates that I couldn't either calculate myself or borrow from the literature in terms of thinking about this, what utility would the individuals get just from not being incarcerated. We know that jails and prisons are very violent places in and of themselves. So presumably there is a willingness to pay of individuals just for not being in that setting. And so I did want to mention that if I did add those components in, then the ratio would even be higher. So to some extent, I think of my ratios as very much even the upper bound might to some extent be a lower bound because of these very important components that we don't necessarily have great estimates for, but that I think that could be thought about and included as well.
Great points. So Fernando in the chat is asking whether or not the MVPF is constructed kind of from the perspective of South Carolina or from the perspective of the US. And I think this is an interesting kind of question that comes up for a lot of MVPF estimates. Sometimes you've got a local policy, but maybe some of the benefits are flowing nationally. I know kind of generally, at least how Ben and I, when we thought about it, was just thinking about a national kind of MVPF, but curious if you thought about kind of the distinctions at different levels of government on where those benefits and costs are accruing in your context.
Yeah, and so in the calculations, I try to include both. For example, when I look at the cost of incarcerating individuals, I look at both the national estimates of how much that costs, as well as in particular for South Carolina, and similarly for the cost of providing Medicaid, I use both costs. But I will say that South Carolina, as I mentioned, is a relatively low-income state, and around a third of its population is Black. So to the extent that incarceration is very high in that state, and the criminal justice system plays a big role in the lives of the individuals individuals, then perhaps we might think that the estimates might be of smaller magnitude in other states. And so I constructed and using, I guess, the numbers both nationally and in South Carolina, but I think that that's a broader question as well for how much of the estimates in themselves, they might be particular to South Carolina for a number of reasons.
So I know we're slightly over the time, but we have a bit of a break here. So for anybody that wants to step out and take a break, happy to. I did have a follow-up question if you're willing to stick around. I think one of the things that I thought was really interesting that relates to kind of other Medicaid expansions, and my segue into some of the stuff that Amy is going to talk about, is kind of, Medicaid eligibility is kind of insurance in and of itself, kind of going back to the way that Gruber and others have kind of thought about it in the past. But you can't always just show up at the hospital and kind of get Medicaid. Presumably if you were eligible and you had a broken leg or something that was very verifiable, the hospital would have an incentive to try to make sure that you were enrolled, and then they would have a very, very easier pathway to doing it. I'm wondering if that process is perhaps more difficult with mental health. And is there an interesting kind of distinction about the extent to which Medicaid has differential implicit insurance for people with mental health versus physical health problems? And if you've thought about that.
Yeah, it's something that I've thought about. And I know that in South Carolina, there is, the process where if you show up at a hospital and it seems to be the case that you'll likely be eligible, they'll just enroll you in that moment and then check later after giving you the services. So I know for physical health, and especially for emergency room visits, that's certainly a component. I will say that a lot of the services that I see being used are these mental health medications, as well as these case management services. And I suspect that access to those services is not as readily available in the same way for mental health care. And so I do think, to the extent that for this age group, Medicaid ends up providing these services quite a bit, and perhaps to some extent more than physical health services for a lot of individuals, then it's not going to serve in the same exact way as just being able to go to the hospital for a physical ailment.
That makes sense. All right.
So a related question. So a lot of hospitals have gotten rid of their mental health services because they've viewed them as losers. And I'm wondering if part of the effects one gets when one cuts back coverage can come from just reducing capacity as it becomes less profitable. Do we have any evidence in South Carolina that's one of the mechanisms? Because I know certainly in the Northeast, that's been a huge issue of shutting down. So even, a wide range of places just, don't offer a lot of the mental health services now, particularly in, extreme situations.
Yeah, that's something I can look into. I have not seen much evidence of that in South Carolina, but not to say that that's not the case. And yeah, it wouldn't surprise me that, given that it's not profitable for many hospitals, it's just not provided in the same way. So that's certainly something I can look into.
All right. So Amy, we're delighted to have Amy Finkelstein presenting subsidizing health insurance for low-income adults. What does it do, and what does that mean? So take it away, Amy. Thanks.
Thanks very much. And thanks to the Policy Insights team for organizing this and for inviting me. This talk, in principle, has two parts. The first, what does subsidizing health insurance for low-income adults do, is something I and many others have spent a lot of time trying to estimate. And it's probably what we spend most of our time on. But what I'm so excited about with the work that Nathan and Ben are doing and have done on the MVPF, and the idea behind the Policy Insights group, is to have us all try and focus in a somewhat systematized way on the second part. What does that mean? And so I'm, in deference to that, going to go very quickly through the what does it do part and try and spend most of my time on how we think about what it means. So by way of background, there is a large and ongoing and visceral debate over the impacts of Medicaid and about expanding Medicaid. These headlines are actually taken from 2008 at the time, right before the Oregon health insurance experiment, but unfortunately you could probably see many of them today as well. You have extreme claims from everything on the left that, you know, we don't have to face hard choices because if you expand Medicaid coverage, you can not only help people but save money in the process, often pointing to the idea that this can improve long-run health or get the uninsured out of the expensive emergency room and into primary care. And then on the right, you have the other extreme claims that Medicaid is a humanitarian catastrophe or worse than no coverage at all because the reimbursement rates to providers are so low, you can't even get in to see a doctor. You're better off uninsured. You know, so as all of us try to do, the question is, can we bring any research to bear to inform this rhetoric? And I was lucky enough, together with Kate Baker and an excellent team of collaborators, to get to study this through the Oregon health insurance experiment, which was a randomized allocation of Medicaid health insurance to low-income uninsured adults between the ages of 19 and 64 that took place in Oregon in 2008. So very briefly, Oregon, like many states, has both a traditional Medicaid program that is available to people who are both sufficiently low income and meet a categorical requirement for eligibility. So for example, they're a child or a pregnant woman or a disabled adult. They also have a separate expansion program, as many states did, to cover low-income uninsured adults who met the financial eligibility requirements. They were below the poverty line, but didn't meet one of these categories. So think of them as able-bodied, low-income adults not on cash welfare between 1964. They may have children, but they are not themselves children. And at the beginning of this program had been closed due to budgetary constraints for a long time. And at the beginning of 2008, the state realized they had enough money to enroll about an additional 10,000 people. And this program, by the way, I should mention, is the program, the eligibility group that they're serving is very similar to the group that subsequently got covered under the Medicaid expansions that came in under Obamacare starting in 2014, starting in 2010. But in any event, they decided they didn't have enough money to cover everyone. In fact, we have since calculated about 200,000 people would have been eligible for these 10,000 slots. And so they decided, actually without any input from us or any other researchers, that the fairest thing to do when you have a limited number of slots and you need to allocate them among eligible people is to hold a lottery. So they ran a big public relations campaign, ads in public health clinics, on buses, on the radio, you know, encourage people to sign up. About 75,000 people signed up, and they drew 10,000 names. After about 2 years, they got enough money to open the list and offer coverage to the remaining people who had not been drawn. So this created the Oregon health insurance experiment and allowed us to study the impact of random assignment of Medicaid coverage to some low-income eligible adults and not others over a 1 to 2 year period. And so, as I said, normally I would be I'm always delighted to spend hours, you know, lovingly going through all the many results of the Oregon health insurance experiment. But in the interest of time, to focus on the what does that mean part, I'm just going to very briefly summarize some of the results. You can find more information about them on our website. But just to sort of summarize what we found, after, you know, from this random assignment of Medicaid coverage for low-income adults, we found that after 1 to 2 years, Medicaid coverage increased healthcare use across the board. So primary care, prescription drugs, preventive care, hospital admissions, and also ER visits. So it's a quite blunt instrument, increasing all types of care. The second main result we found is that Medicaid did what health insurance is designed to do, which is improve economic security or smooth marginal utility of consumption across the states of being sick and healthy. So it reduced out-of-pocket medical spending, it reduced medical debt. Perhaps, I think most importantly to us, thinking about this from the economic perspective of insurance, it eliminated so-called catastrophic out-of-pocket medical spending, which has been defined by others as a household spending 30% or more of its income on medical expenses. So that's what you really want to do, cut the right tail of medical expenses. We found no detectable effect, though, on earnings or employment. And finally, the results results on the health effects of Medicaid, at least in the first 1 to 2 years, were somewhat mixed. On the one hand, across the board, it improved all kinds of self-reported measures of health, both physical and mental health. And in addition, when we administered depression screens, which is sort of how a shortened version of the screen that's used to clinically diagnose depression in a doctor's office, when we administered them to both the treatment and control group, we found really striking reductions in rates of measured depression, about a 10 percentage point reduction or 30% decline. On the other hand, we found no detectable effect on measures of physical health that we could measure in these first 1 to 2 years, such as blood pressure. These results produced a tremendous media response with a wide variety of conclusions. Everything from Oregon's lesson to the nation is that Medicaid works, to spending on Medicaid doesn't actually help the poor. There was also a lot of what we might say is informal welfare analysis that was, fairly inconclusive. Basically, different organizations focused on a subset of results, either, if they wanted to claim victory for Medicaid, the mental health results or the increased economic security, or if they wanted to claim failure, the lack of physical health benefits, assigned arbitrary dollar values to those and came to their conclusion, either that Medicaid makes big difference in lives, study finds, or study on Medicaid doesn't actually help the poor. So with that as an admittedly fairly low bar, the question Nathan and I, together with Mark Shepard and Erzo Lutmer, set out to answer is, could we learn something more from formal welfare analysis, right? The goal is always to keep the bar low. So hopefully I will convince you that we can. So our goal more specifically, at least initially, was to estimate the monetary value of Medicaid to recipients. And the first and hopefully obvious point, but just at the risk of stating the obvious, any this type of welfare analysis, at least that we're doing here, will require more assumptions and therefore more caveats than the direct experimental estimates of the impact. What happened to prescription drug utilization? What happened to out-of-pocket medical spending? That doesn't mean we shouldn't do it. I actually think it's probably one of the real comparative advantages of economists as opposed to other excellent empirical social scientists. But it does mean that that's important to keep in mind. And in part because of that, we undertook two very different approaches, which I'll tell you about. And somewhat to my surprise, we found a quite robust result across these approaches as well as within them, which was that Medicaid's value to recipients is substantially below Medicaid expenditure. So the people who are receiving Medicaid through the Oregon expansion, which, as I mentioned, is similar to the population that's getting Medicaid under the Obamacare expansions, are receiving about 20 to 50 cents on the dollar in value to them for every dollar that Medicaid spends. And what made us feel pretty confident that we were onto something was not just that different approaches yielded somewhat similar results, but also that eventually we came to understand what was driving them, which is that the low-income individuals who are nominally uninsured and therefore getting formal coverage for the first time through Medicaid, in fact, already have a substantial amount of implicit or informal insurance. And so they're paying only a small share of their medical costs. So we estimate in Oregon, they're paying only about 20 cents on the dollar for their medical care. Other studies in other contexts or nationally have estimated anywhere from 20 to 35 cents on the dollar. And the reason that's really important is that both the estimates I've just talked about and the initial welfare analysis I'm going to show you is focusing on the value of Medicaid to recipients. But part of what we're going to learn from this exercise is that there's another important beneficiary of Medicaid coverage who are not the recipients of Medicaid, but the actors, be they state governments, hospitals, et cetera, who were otherwise bearing 80 cents on the dollar of the costs to the uninsured. And that's going to be extremely important for thinking about our welfare analysis. And just to preview where I'm going, what's going to turn out to be very important is ultimately the economic incidence of the costs borne by these implicit insurers. Spoiler alert, or lack of spoiler alert, I won't have an answer to that question, but I will show you how the welfare analysis, or the MVPF, is affected by different assumptions. And I think it's an incredibly important, albeit challenging, area for further work that I hope many people, including those in the audience, may be inspired to take up. All right, so with that by way of background, let me briefly describe the framework, which is going to apply to both of these approaches. We're going to think about individuals deriving utility or well-being from both health, H, and non-medical consumption, C, and then potentially other things as well. Health is produced according to a health production function, which health is a function of M, medical spending. So as is traditional in this sort of approach, we don't assume that any individuals get direct utility from medical spending, but rather medical spending is an input into health from which you derive utility. And health also depends on a distribution of potential health shocks, theta, which is where the insurance value of Medicaid or any health insurance program is coming from. So our goal is to estimate the recipient's value of Medicaid, which we're going to define V. You can think of it as the amount of money that we could take away from a Medicaid recipient that would leave him indifferent between having Medicaid without V and being uninsured. So kind of an equivalent variation notion. And as I already alluded to, and I just want to emphasize, and then I'll come back to it, the recipient's value of Medicaid may well be different from society's value of Medicaid, not only because of what I already mentioned, that a large share of the dollars from Medicaid expansions are going to someone other than the recipient, but also because we may have redistributive aims through our social welfare function. But I'm going to start with the recipient's value and then come back to that. So we took two different approaches, as I mentioned, to estimating this value of Medicaid. In the first approach, which I call the ex post approach, we simply take the estimated outcomes for individuals with Medicaid and without Medicaid from the Oregon Health Insurance Experiment. I sort of briefly summarize those results and use it to infer and compare utility with and without Medicaid. And in what I refer to as the ex ante approach, we instead try to estimate the demand curve for Medicaid, so and assume that this demand curve reveals individuals' preferences or willingness to pay or value of health insurance. All right, so let me just tell you a little bit more about each of these approaches. If you want to learn more, they're discussed respectively in our JPE paper with Erzo and our AR paper with Mark. So as I said, V is the amount of consumption we can take away when an individual has Medicaid that leaves him with the same expected utility as without Medicaid. So this utility expectations are taking over theta, the distribution of health shocks. Utility when you are uninsured is just a function of your consumption when you're uninsured and your health when you're uninsured. Utility when you're insured is a function of your consumption and health when you're insured. And here we're going to take away V from your consumption to make these two equal. So to solve for V, we need the potential outcomes, consumption and health with and without insurance. Those we know directly from the experiment. And then we need some functional form and parameters for the utility function U. So where does that come from? Well, we make it up. Sorry, that was a Freudian slip. I meant we carefully calibrate it using standard parameters from the literature. So in particular, we make a functional form assumption about utility, that utility is additively separable in consumption and health, that it's linear in health, and that it's constant relative risk aversion in consumption. The particular functional forms are not essential. We can do other things. We do want to have some concavity over consumption to get the notion of the insurance value of Medicaid. This sigma is going to be the coefficient of relative risk aversion, and phi is going to be the marginal value of health in units of consumption. Once we've parameterized that, then we can simply plug that parameterization into this formula and get V as the implicit solution to it. And we can use the cross-sectional distribution of outcomes in both the treatment group and the control group to represent the potential realization of the states of the world with and without insurance. All right, so that's the ex post approach. The other approach we take, which I call the ex ante approach, is to assume that to estimate the demand curve for Medicaid, revealing the willingness to pay for insurance. So in this case, V, the value of insurance for each individual, is simply the maximum price at which she's indifferent between buying insurance and getting the consumption and health bundles that come with having insurance, or the distribution of those bundles, or remaining uninsured and not having to pay for Medicaid. The key assumption to use this for normative analysis is that it requires that the demand curve is revealing preference, or V, which requires that individuals are making privately optimal decisions, right? So if we're concerned that individuals are inattentive, misinformed about Medicaid or about the health risks they face, et cetera, the demand curve may not reveal value. If we're not concerned about that, or even if we are, implementation simply requires that we have random variation in prices so we can trace out the demand curve as a function of the price. And while that's often hard to do with publicly provided goods, because by definition, they're not traded usually in a well-functioning market, we were fortunate enough to have an application from right here in our home state of Massachusetts through the so-called Romney Care reform, which was the precursor to the Affordable Care Act, in which Massachusetts introduced universal health insurance coverage in 2006. And if they're going to mandate coverage, it had to be affordable. So they introduced subsidies for low-income, non-elderly, uninsured adults to be able to buy insurance. And those subsidies varied as a function of the poverty line. And because those subsidies varied at discrete levels of the poverty line, so what the commission decided constituted affordability was different if you were at 150% of poverty than if you were at 200% of poverty, we were able to use a regression discontinuity design. And this is just designed to give you an idea that the monthly premiums, increase discretely at 150% of the poverty line, 200%, 250% of the poverty line. So we're able to use that to estimate a demand curve. The share of the eligible population that's insured also drops by about, discretely and by about 25% every time the premium goes up. So in other words, demand curves slope down. You heard it here first. We can use this to construct a demand curve. And the type of result we get is that, for example, half the eligible sample values insurance, if we're going to take a reveal preference approach, at less than $77 per month. And we can compare that to the cost, which is about 3 to 4 times higher, the Medicaid expenditures that they would receive. All right, so both of these approaches have strengths and weaknesses, and in some sense, they're the mirror image of each other. So one thing that I think is really nice about the ex post approach is it provides a direct mapping from the experimental estimates of the impact of Medicaid on health and consumption to its value. It was our attempt to discipline, what we saw as these, somewhat loose, let's cherry pick the results and assign an arbitrary dollar value to them that I put up earlier. And unlike the ex ante approach, we don't have to take a stand on whether the individual themselves is making insurance choices or medical care consumption choices optimally, because we as the researcher are imposing a utility function. We know their preferences. That, of course, is also the cost. We have to be willing to assume or impose a specific utility function. Right? The ex ante approach, in some senses, as I said, the mirror image of that, the big plus or feature from my perspective is that we don't have to specify a utility function, not just the functional form of it and the parameter values, but even the arguments of it, right? So we looked at consumption and health, but if you think that Medicaid is also going to affect, for example, crime, as we saw in Elisa's presentation, or marital formation or children's outcomes, we don't have to keep adding, additional estimates and arguments. On the other hand, the downside of it is that you do have to assume that the demand curve is revealing people's preferences and ignore a large body of and growing body of evidence in behavioral economics suggesting otherwise, both in health insurance and in other settings. Fortunately, I guess, for us, the two approaches with their different strengths and weaknesses yield what we thought of as quite broadly similar results. As I mentioned earlier, the key finding that we have is that the value of Medicaid to recipients is substantially below what it costs Medicaid to provide that insurance. And that's not talking about administrative costs, that's just purely medical claims payments. The value is about 1/5 to 1/2 the costs, or another way of saying that is Medicaid recipients value every dollar of Medicaid expenditure they receive by about 20 to 50 cents. That result is consistent, by the way, with the very limited take-up of the very heavily subsidized health insurance, both in our Massachusetts setting and otherwise. And the implication of it is that the low-income uninsured would prefer to be uninsured than to have Medicaid if they had to pay for it. So the fact that two different approaches yield similar results is useful and nice. On the other hand, I mentioned that they both have their limitations, and perhaps they're both just misleadingly getting us these results. The thing that made me at least feel that we were really onto something is that we understand, both in the world and in a modeling sense, what is driving this result, which is it comes from something we had never really looked at in the Oregon experiment when we were focused on the impact of Medicaid on the recipients, is that there's another large group of recipients, because the low-income, nominally uninsured individuals already have substantial implicit insurance. So as I mentioned before, a large share of their medical costs when they're nominally uninsured are not actually ones they pay for. They're either provided by charity care, so federally qualified health clinics, nonprofit hospitals, et cetera, so-called ex ante or deliberate charity care, and also in the form of bad debt, medical debts that they incur when they need health care that they then can't pay, which is why we found that Medicaid lowered that debt, but that is otherwise ultimately rarely paid, and therefore borne in first instance by the hospital and ultimately by someone, identity so far unknown. The result is that 60 cents of every Medicaid dollar we estimate in the Oregon experiment is a transfer to providers of this implicit insurance. And this lowers the value of Medicaid to the recipients for two reasons. First, because 60 cents of every dollar just isn't going to them, right? And second, because of concavity of the utility function. We know that the first unit of insurance is the most valuable. The uninsured are only paying on average about 20 cents on the dollar for their medical care. So another way of thinking about that is they kind of already have an 80% insurance policy. So both of those are going to lower the value. Okay. As I said, up till now, though, we've just focused on Medicaid's value to the recipient. We now want to think about Medicaid as a redistributive policy and think about society's value, which may exceed the recipient's value, because first, mechanically, the poor are going to have lower willingness to pay because they have lower consumption and therefore a higher marginal utility of consumption, and therefore a higher marginal disutility of giving up consumption. And second, and relatedly, because typical social welfare functions receive some additional value or welfare from providing redistribution, from transferring money across people with lower marginal utilities of consumption, the rich, to higher marginal utilities of consumption, the poor. And as we know, from Arthur Oken's famous example of the leaky bucket, that if you want to do redistribution from rich to poor, it's like trying to transfer water in a bucket from the rich to the poor. That bucket inevitably has holes in which some water leaks out. Redistribution is never costless, and we tend to tolerate that as a society. We're typically willing to spend more than $1 to transfer $1 to the poor. And so this is where the entire agenda of the Policy Insights Lab and the work that Nathan and Ben are doing becomes extremely important. One important question is not just, how big are those leaks, but how do those leaks compare to other potential types of transfers we could be doing? We can, so that we can, then consider, which policies have the greatest bang for their buck, right? And if we want to estimate the leaks from Medicaid so that we can compare them to other MVPFs in the growing MVPF library, a key challenge is figuring out where the 60 cents on the dollar that's going to non-recipients is actually ultimately going. If that's really just, a transfer to hospital CEOs who have a relatively low value in our social welfare function because they have a high consumption and hence low marginal utility of consumption, the MVPF is going to look very different than if, in fact, most of that money that the hospital is saving and no longer having to treat some low-income uninsured patients is going to provide better care to other low-income patients. So as I said, we don't know the answer to that, but I want to briefly discuss the MVPF framework and how, if we did know the answer, it would affect the numbers by showing a bunch of different approaches. And so to do this just concretely, I'm going to consider in the Massachusetts case, the marginal value of public funds of increasing the health insurance subsidy for low-income individuals. And as Elisa already very helpfully explained, the MVPF is simply the ratio of benefits to costs, or the marginal willingness to pay to the recipients to the marginal cost to the government. So we're going to assume that we start with some fraction S of the eligible population who's insured, and then we're going to raise the subsidy, the government subsidy for insurance to this eligible population for $1. So this makes the numerator very easy for us. It's much harder in the case of the Oregon experiment, where we don't get to observe pay. We don't see purchase decisions, and therefore we have to try and infer the value using the ex post approach. Here we know that anyone who's already insured, who gets an extra $1 of subsidy but would have bought the insurance anyway, their value of $1 is $1, and there's S star of them. And by the envelope theorem, the individuals who weren't buying insurance but are now going to buy it with the extra $1 of subsidy, we don't have to worry about any utility gains to them. The denominator is the cost to the government, which is just for the S star inframarginal people. It's the extra $1 that they're paying in subsidies for each of them. And then it's the increased costs to the marginal guys. So apologies for the notation, which I haven't explained. W you can just think of as the willingness to pay or the demand curve. So 1 over the slope of the demand curve is just a measure of the number of marginal entrants, the newly insured new people who get insurance because of the subsidy, and costs minus the willingness to pay or the premium of those marginal guys just measures the government cost of the entrance, right? So we're measuring the benefits, which are $1, over the costs, which are $1 for the inframarginal guys, plus the difference between costs and willingness to pay for all the inframarginal guys. And just to emphasize up front, you might think, well, obviously the marginal guy's willingness to pay is going to be less than the cost because they weren't buying it without the subsidy. That's true of a traditional market like broccoli. But if you think, as we need to educate some former Supreme Court justices, that insurance and broccoli are different, you would remember that, say, for various market failures like adverse selection, it may well be that the willingness to pay for the marginal guys actually exceeds the cost. So it's an empirical question. Okay, so that's the general formula. What's complicating it in our case is none of this is assuming as if that, we're not paying any attention to the 60 cents on the dollar of Medicaid payments that are just going to pay for the care that the uninsured were already getting, or to be more concrete, it's coming into the cost, but it's not coming into any benefits. So there's a number of ways we can handle it in the MVPF framework, depending on what you think of the incidence of uncompensated care. So one is you can just ignore it, assume that it falls on, whoever is getting those 60 cents have no social welfare weight. Another is to assume, which has some, mapping to at least some of reality, that actually any decrease in these uncompensated care costs are basically savings to the government, who finances a lot of this quote unquote uncompensated care through tax subsidies to nonprofit hospitals, through direct grants to federally qualified health centers, et cetera. And in that case, we would just take it out of the denominator so that the cost to the government, we would now have this cost term C be the net cost, not the gross cost. The other option is that it's accruing to some external party, in which case we need to add it to the numerator. These are people not optimizing individuals making choices, but benefiting from it. And here what's going to matter critically is whether we think the benefits come to low-income individuals who might have a high social welfare weight, or to higher-income individuals who might have a lower social welfare weight. And here we use a half, which is based on other work that Nathan's done on the sort of marginal value of public funds of transferring money via tax increases on the rich to the poor. So let me just show you what these results look like. We'll start from, like Elisa, we'll show a range of estimates. We'll start with the assumption that there's no uncompensated care. So 60 cents on the dollar is just being burned. Needless to say, or I guess leaked to not mix metaphors. Needless to say, that's going to lower the MVPFs. We consider two different cases, one in which we start with 30, we have subsidies such that 30% of the population is insured, and we're adding $1 of subsidy. The other one we start with 90% insured. And then we'll consider the three other cases of the various uncompensated care incidents. I don't know which is right or which combination of them is right. I strongly suspect the no uncompensated care is an extreme and an unlikely one. And what you'll see is that, the results are going to vary differently quite a lot, whether if the incidence of this uncompensated care is either on the government that can reduce other payments or on the low income uninsured compared to if it's on the affluent. To put this in perspective, we tried two different benchmarks. One is to ask, just on an absolute scale, is this program worth it relative to, say, what a social planner with a utilitarian social welfare function and utility functions that are concave with coefficient of risk aversion 3 would be willing to spend. And on the one hand, the answer is yes, for any of these metrics, that this utilitarian social planner would be willing to spend, would be willing to do these transfers even if they were only worth 20 cents on the dollar. It's not quite clear what to make of this. This is a sort of well-known result that by any sort of standard or typical welfare calculation suggests we should be doing a lot more redistribution than we're currently doing. So that either suggests that our standard utilitarian framework has some problems, or our political system has some problems. I'll leave it to everyone to form their own judgments there. But perhaps because of that, another useful benchmark is to, as I mentioned earlier, is to compare it to other programs that might similarly benefit or likewise benefit a low-income adult population, such as the Earned Income Tax Credit, which Nathan had estimated in other work, might have an MVPF of 0.9. I think subsequently he's done work after we did this that suggests it's even higher. All right, so just to wrap up, because I see that I'm already out of time, the sort of agenda here is to figure out, what does health insurance expansions for low-income adults do, and what does it mean? The doing part is always challenging because we need good identification, but once we have that, it comes relatively straightforwardly, and we find that Medicaid benefits recipients. It improves their health, reduces out-of-pocket spending, and lowers medical debt. The other thing we find, which I don't think we knew to look for until we started thinking about this MVPF framework, is that Medicaid also produces large transfers to non-recipients. About 60 cents of every Medicaid dollar is going to providers of charity care for the low-income uninsured, which means both that they have already substantial implicit insurance, which is going to lower the value of formal insurance, but in addition, it also means that a complete welfare analysis of a Medicaid expansion can't ignore these other beneficiaries who are not Medicaid recipients. If we do, and we look at just the value of Medicaid to recipients, we get that it's about 20 to 50 cents on the dollar. When we try to incorporate these transfers to non-recipients, we conclude that as a way to redistribute to the poor, Medicaid may deliver less bang for the buck than cash transfers through the tax system, unless the incidence of the costs of that uncompensated care is falling very heavily on the low-income recipients themselves. So thank you very much. I think I'm out of time, and hopefully Nathan's been expertly fielding questions in the chat. I guess I'll stop sharing so that I can see you a little more.
I think you were sufficiently clear along the way that there's no open questions in the chat. For anybody that does have questions, please do feel free to post them in the Q&A now. But I guess I'll go ahead and take the liberty of a question. I see Hilary, go for it.
Hi, thanks for that. I have a question that sort of backs out of the MVPF and sort of circles back to the original estimates. And in thinking about the very, well documented point that, the incidence, that this doesn't represent $1 over and above what the recipients would have faced in the absence of Medicaid, it does sort of allow one to have a different context for thinking about the magnitudes of your original findings, in terms of the effects on mental health. And I wonder whether you've thought about whether that changes in any way your interpretation. Particularly, I guess I'm thinking about the sort of mental health findings that I've always thought about relating to having insurance and that fundamental aspect of having Medicaid, and how the uncompensated care reality then influences your interpretation of those impacts.
So I'm trying to unpack your question. We did find, and I was very struck by them, these really substantial mental health benefits. In fact, the first and really sobering fact is just that in the control group of uninsured low-income adults, when we administered a depression screen, 30% of them screened positive for depression, but that Medicaid decreased that by 10 percentage points. So is your question, what is the role of uncompensated care in not having that 30% number be higher? Or how do I think about the value of those mental health benefits from formal insurance, or both?
I guess it's more the latter.
Okay.
I mean, is it that, like folks don't know they're getting uncompensated care, so they bear these big costs, part of which they don't fundamentally actually pay in the end. Or maybe it just makes the mental health effects even larger than maybe they looked on the surface when one didn't account for that, I guess.
So it's a really good question, and I'm not going to have a complete answer to it, but I can tell you a few things. So the first is we also see a big increase due to Medicaid in the probability of taking prescription drugs for mental health. But even if you thought that anyone who newly started taking those drugs, it was going to be effective for, which unfortunately is not the case, the increase in prescription drug treatment alone is not sufficient to account for the entire 10 percentage point drop. So something else must be going on. It could be better matches to the type of prescription drugs. So a physician who's now able to play with the right form of drugs and switch you around. It could be mental health services. I personally, and from our focal groups, have a bit of an intuition, which is where I think you may be going from, is it part of what we are detecting as a decline in depression is just a improved overall sense of well-being, a reduction in anxiety, because sort of the psychological component of the economic consumption smoothing, like just less risk and uncertainty. If you talk to a clinician or a clinical researcher, they feel very strongly that the depression screen measures depression, and generalized anxiety and well-being is, not captured there. Now, I'm not a clinician. I can't comment on that, but I share your sense that that's going on. And more generally, some of these self-reported health questions, which we just see moving, I feel better physically and mentally, that some of that may be health, and some of that may be I'm just less worried about, the next time myself, I have a health problem. So, and that's because, let me be clear, and it's important not to overstate this implicit insurance. Like, there's no question from the results of the Oregon experiment that having insurance makes people better off than having this implicit insurance. Those results are clear. They have, improved economic security, better self-reported health, reduced depression. It's just that the increment is not as big as it would have been if there hadn't been that uncompensated care to begin with.
Thank you.
Awesome. So in the interest of keeping on schedule, there's two questions still in the Q&A that people have submitted that I will just let Amy and myself handle just in typed responses in the next few minutes, but just to keep rolling along. Oh, Elisa, I see you have a question as well. Did you want to take a last quick question and then we'll move to the next one?
Sure, only if there's time. Otherwise, I can also type it in. But my just quick question is, As we think about just insurance being expanded sort of in a long-term perspective, do we expect that this share of transfers or this portion that's going to these individuals to be reduced over time? And how do we think about incorporating that into the MVPF? And I guess my second question related to that is, do you have any sense or any just intuition of do hospital owners or like, are there any parties that play a role in sort of negotiating the reimbursement rates that could give us a clue about whether they are the ones that are bearing the incidence, or is there something about the way that this all works that can give us hints about it?
Yeah, so I heed Nathan to be concise, so I'll just very quickly say, one, there's lots of newspaper articles about how hospitals and hospital associations have lobbied for Medicaid expansions and against their repeal, so that's a clue. And yes, I think even the ACA was funded in large part by reducing some payments for uncompensated care. That's complicated because then if you're comparing, $1 of cash versus $1 of Medicaid, you have to take into account that the $1 of Medicaid may only be 80 cents of new dollars into the system if part of it's being paid for by the clawback. But it's a really interesting and important question.
Awesome. And there's a question in the chat related to prices, but I'll let that be handled in the chat, and we'll move on to sectoral job training programs. So Larry, if you're comfortable sharing your slides as well.
Okay, I will just do so.
So we're going to have Larry Katz presenting on why do sectoral employment programs work, lessons from Work Advance. So feel free to take it away.
So this is joint work with Jonathan Roth, who is now at Brown, and with our colleagues and collaborators in MDRC, Richard Hendren and Kelly Schauberg. And this is going to be an area where I think the MVPF conclusions is changing very rapidly as longer and longer follow-up is available in the data. And it's going to be an area where how far out you look at the results are going to matter a lot because it really is about human capital investments in individual workers. And so that's going to be a key issue in thinking about this. So I want to start with a few pieces of motivation and then get into the sort of details. We all know there's been substantial growing, earnings inequality and divide between college and non-college workers, with stagnating real earnings for non-college workers in the United States. Along with that, there's rising, as we've gotten very good administrative employer-employee match data and estimated AKM models, we've learned that there's rising sorting and segregation in the labor market, with high-wage workers and more advantaged workers increasingly working in high-wage firms, and less advantaged workers finding a harder way of getting pathways into high-wage employers, particularly non-college ones. And at the same time, there's growing evidence that on the margin, traditional higher education, four-year selective public colleges, as well as strong community college programs like nursing programs, have very high returns. The second motivation is that that's certainly suggestive of the value, and we see this in the current budget, the push for free community college, of expanding those types of programs. But there are a lot of individuals who fail to thrive in traditional post-secondary programs, particularly without further supports. And the question that sectoral employment training programs try to answer is, how do we assist individuals who may have childcare obligations, may have been in a community college and not done that well and not be that turned on, may have other work constraints, who have essentially the basic skills and motivation that they should be able to move into high wage jobs and expanding sectors if they had appropriate training, but often lack access to appropriate training or connections, or look like the type of person an employer in that sector would hire. And sectoral employment programs have emerged as a promising approach to workforce development to, target a particular group of disadvantaged workers, those who can at least, get through some initial screens of motivation and basic skills. So we're talking about like 6th grade, 8th grade math and literacy, not, having a PhD in physics. And in particular is becoming, important in federal and state and local policy. Our major job training bill, the WIOA, Workforce Innovation and Opportunity Act of 2014, encourages states and local governments to shift towards sector-based training programs with evidence. And there's $3 billion in the American Rescue Act, at the discretion of the Secretary of Commerce, Gina Raimondo, which was just allocated about a month ago, 500 million of it to what she called the Good Jobs Challenge, targeted at sectoral employment training programs in distressed areas. So understanding what they do and whether they are more advantageous than traditional training programs, which have a very checkered history, is an important and currently relevant policy issue. And sectoral employment programs try to train job seekers for, quote, high quality employment measured by industries and occupational clusters that have two key features: strong current demand. There are jobs today, employers are looking to hire people, you can place people in them, and they are opportunities for longer term career advancement. So the gap between a starting position and a typical person in that occupation and sector and earnings is quite large. So we think there are growth possibilities. And they've tended to target sectors such as IT, healthcare, manufacturing, and business and finance. And they operate by building strong connections with employers. It's sort of a dual customer model. They view both the individuals getting trained and employers as potential customers. And we have a growing amount of RCT evidence, starting with the 2010 Sectoral Employment Impact Study by Public-Private Ventures, and now covering programs 9+ years out. In fact, there'll be 11 or 12-year results next month available for one of these programs, Project Quest. So the question we ask in this paper is we re-examine the evidence from 9 different randomized control trials that are available on 8 different programs. One of them, Perskalos in the Bronx, which is a program of training IT individuals, has actually been in 2 different ones of these RCTs in the early 2000s and the 2010s, and both with striking positive impacts of sort of 30% earnings gains. So we actually have different types of replication evidence, same program in different eras, and programs, new programs and existing ones. So we seek to understand the sources of what we're going to see as a pretty strong evidence of positive and sustained earning impacts by looking at the components and trying to directly test some of the mechanisms. And we're going to argue that it's really the key is getting people into high wage growing sectors, that it's really the occupations and industries they target. Programs like this that don't target high wage sectors, for example, one we'll see that didn't work, that targeted jobs in the pest control sector, not actually a really high wage earning ones, don't seem to deliver those payoff. And the other thing is it's not just about the connections. They matter. We're going to also see that if without the training, you don't seem to get much of this return. You can't just refer people without the training to sort of the high wage jobs. They have to have, the sets. Those are actually a key sort of entryway. And what's partially motivated me and our authors is the fact that I actually, when I was the chief economist of the U.S. Department of Labor, in the Clinton administration, we actually did a huge review of all the employment and training programs at that time, finding this very mixed record of responses of outcomes that you can see in the MVPFs up on the Program Impacts website, most of them not being that great. But we did find a few slivers of hope, and one particularly the Center for Employment Training in San Jose, who had very much a model like what we're going to see in sectoral employment training programs, seem to be quite successful. In fact, after our review, the US Department of Labor tried to get the Center for Employment Training in San Jose to set up 11 more sites in different cities. And it's one of these failed replication analyses that without the existing, without a lot more than just this charismatic leader, it didn't seem to work. And so this sort of died out. But then in the early 2000s, a group of nonprofits and advocacy groups started, working with community colleges and local community organizations, started setting up programs that look like this at the grassroots level, rather than being transplanted from San Jose. And we're going to see that they look incredibly successful, a lot like the early evaluation of the Center for Employment Training. So the one I'm going to focus on for getting into, a lot of the sort of mechanisms is what's known as Work Advance, which was put together by MDRC. And as I noted, these are dual customer models. Tries to connect low-income job seekers to high-demand sectors and employers and jobs that offer a strong career pathway. The starting point is, there is some upfront screening and intake. The screening is of two types: motivation, which is largely, do you show up to several different meetings, and some, as I said, 6th to 10th grade, depending on the program, grade, reading and math, so some basics. So it's not every disadvantaged job seeker, but a very large group. That then combines career readiness training, often known as soft skills or life skills training, as a key component, several days a week, and more full-time occupational and skills training customized to a specific sector, but not to a specific employer. So a key thing here is the goal is to generate a set of skills that isn't just enhancing the monopsony power of one employer, but is a set of skills that a broader sector is looking for. So think of transferable skills, often a certification, could be a nursing or health technician one, could be things like Cisco certified for working with routers, or Apple certified technician. There's a lot of hand-holding and wraparound services to try to make sure people's childcare issues and other stressors of daily life don't disrupt being able to do the training and start work in higher wage jobs, combined with close working with employers in a sector, and post-placement services, very important for assuring employers that someone with a non-traditional background, if a communication problem occurs, someone from the program who they know well could be there to help mediate and facilitate that. So that's the basic idea that all of these programs are, and the sort of thoughts on the mechanisms. There's the traditional, we're really providing training, 3 to 6 months typically, of soft skills and occupational skills training. So it's the actual human capital. There's also a view the wraparound support services may be needed in order to allow people with difficult life circumstances to complete the training and to form connections with employers, the role of an intermediary, and the post-employment services. What we're going to see is that you seem to need all of these, and if you get rid of number one, you don't really find much impact. So it isn't just connections without actually having the training and skills to get into it. That is actually a barrier, and one, employers do not provide themselves to disadvantaged workers very often without the types of support systems that sectoral employment and intermediaries play a role. So theoretically, we can think of going back to the classic Margaret Stevens work in the 90s on why would certain training, the standard Becker model says general human capital should be paid for workers, specific human capital employers will provide joint pay. But what about stuff that's in between? It's not completely general, it applies to some group of employers. What if there are frictions? That's where employers may not provide it because of poaching externalities. Workers might not be willing to pay for it because some of it's going to be extracted, by employers' monopsony power. And so that's where you're going to tend to see under provision in the labor market of what might be very valuable training. there are dynamic inefficiencies also, that if training providers aren't aware of the way things are shifting, don't have good communication with employers, you're not going to take advantage of those changes. Perscolas, which is the one that's had 2 evaluations, is a great example of the dynamic benefits. In the 90s, they were training people to sort of repair PCs, and that was very lucrative. That would not be a very valuable way to train people if we kept a program doing that in the 2010s and 20s, where they switched to sort of getting people Apple certified and sort of working with routers and other things. So you need to actually shift them with the labor market. And there are the role of the wraparound services in keeping people engaged in these programs and linking to employers. And finally, the vouching may be an important role in reducing discriminatory and information barriers that many non-traditional workers may face in moving into high-wage jobs. So some of the implications are that the gains should come largely through moving people into higher wage employers, industries, and sectors, and that the screening and other things by themselves, if it's really the human capital also, won't be enough. And finally, and this will be important in considering the way we do the MVPFs and others are thinking about it, are general equilibrium issues. One worry of programs like this, you might think, is this just musical chairs? I get one person into a high wage job and I displace another worker. So I get a kid from Roxbury in, and I displace this, a BU student who would have gone to State Street Bank and taken this job. Well, one reason we think that the displacement is likely minimized is it's targeting growing sectors and employers who are having tough times hiring people. The second is we think the types of people who might get displaced have pretty good outside opportunities, at least in non-recession periods. The third is this really is not just the placement part, it's expanding the supply of human capital in these sort of higher wage jobs. And the final is it may actually have positive general equilibrium effects in getting employers to take seriously people with non-traditional credentials and expanding them to seek out, train, and hire more of them, sort of the micro foundation of the Shea, Hurst, Jones, and Klenow finding that a large part of US economic growth is reducing discriminatory barriers by ethnicity and gender for moving into higher wage, getting training and moving education and moving into higher wage occupations and industries. So what is the evidence for how sectoral employment training programs? As I noted, there are 4 sort of major RCTs with 9 randomized controlled trials embedded in them over the last decade, starting with the sectoral employment impact study of public-private ventures, Work Advance of MDRC that I've been working on, which has 4 different programs, Project Quest, which is in San Antonio and in Texas, which works in the health industry, and Year Up, which works with youth. So these programs cover youth 18 to 24 from disadvantaged backgrounds, disproportionately minority youth. Year Up, single moms moving back into the workforce, as in Project Quest, is about 90% Hispanic women in their 30s and their 40s. A broad range of the sectoral employment of people who may have dropped out of community college in a program like Perscolas. So, and what we're finding is gains, found for low-income adult men and adult women, youth and young adults with that should say without college degrees, not with college degrees here, but with some screening on basic skills and motivation. And across these 9 different RCTs, 52% of the participants are Black, 26% Latino, very few have traditional college degrees, although many of them have some experience, say, in community college before. And so this is the basic summary of the sort of 9 RCTs. And what you can see is if you take it out, to, sort of beyond 2 years, in the end line sort of analysis, in 8 of the 9, we're getting positive impacts, pretty positive impacts, with the exception, being the initial findings in St. Nick's and Project Quest, which is sort of negative to start, ends up very high after 9 years. And some of them have remarkable impacts that we haven't seen. Project Year Up, which is operating in sort of 15 US major cities with thousands of youth now, is generating 40% earnings gains, 3 years, still 34% earnings gains 5 years out. And I think some figures, that look like Jacob Mincer could have drawn them in sort of the period while you're training and getting these programs, the negative effects and then the growth sort of show what's going on. And I think these are very plausible because these really are RCTs comparing treatment control groups. So this is from the initial sectoral employment study covering one IT-based program, Periscolas, one manufacturing, the Wisconsin Regional Training Partnership, and one health one, the Jewish Vocational Services in Boston. And you see the classic modest losses in earnings while you're undergoing the training. And once you move out in the labor market, you start seeing the 30%, 40% earnings gains persisting through 2 years that the original study looked at. And the other key thing is there's no change in employment rates. It's all getting people into higher wage jobs, which is something typically traditional training programs haven't done. They tend to historically get people into the same type of jobs they would normally get, but more quickly. Here, and this is in sort of the early 2000s, $13 an hour is like $18 an hour today. It's hugely increasing the share moving into higher wage jobs. And if we look at Work Advance, which I focus more on, again, 4 different sites, one being the same, Periscolas, 2 of them new startups, Madison Strategies and Towards Employment. Again, what we find is here, these are sort of 12 to 15% earnings effects going out 3 years, and we've now seen similar gains going out 6 years, with Periscolas being even larger. In Project Quest, it's 2 years of negative effects because they're doing 2-year nursing programs, but once they finish, large earnings gains at $5,000 a year in year 9, sort of 20% persistent earnings over the next 7 years, with a 90% female, 74% Hispanic population. And the most striking being Year Up, which is my local program. In fact, the founder, Gerald Chertavian, lives a few houses down from where I'm sitting right now, talks about ABCs. You need the initial skills, the training, the certification to get in, but you persist in these jobs, he argues, through the life skills, soft skills sort of training, attitude, behavior, and communication skills. And what you see here from Year Up is, again, it's 6 months of a sort of internship of the training the training in the classroom, then 6-month internship with one of these employers. And the minute the internship ends, you see these huge gains of moving into the regular labor market. Some of that is staying with the same employer. Most of it is getting hired at other high wage employers. And so we're seeing 50% earnings impacts 3 years out. There's still 35, 40% earnings impacts, 5 to 6 years out. So how do we think about the benefits and costs of this program? I'm going to start with a traditional benefit cost analysis like that shows up in the MDRC report by Schauberg and Greenberg, and then use that to move towards the MVPF approach that Nathan and Ben have done for these sorts of programs. And what you can see here, so this is from Work Advance, the Periscolas one, where we have data out 5 years from random assignment, actually 5 years and 3 months, is with traditional benefit cost analysis, this program looks very good because of the large earning gains we've seen. That over the first 5 years, there's about a $29,000 increase in earnings for the treatment relative to the control group. And so if we look at traditional benefit cost analysis at the individual level, we would look at their gains in earnings and benefits and compare them, to the extra taxes they pay, the losses and benefits. And at the individual level, this program looks very good. The sort of net gains look like 18,000. If you try to value the extra time they were spending during the program in the training as loss of leisure, it might look like about a $14,000 gain over 5 years. And for a society as a whole, this also looks, very powerful in traditional benefit cost, sort of 27,000 benefits, and the net program costs are about 5,000, 4 to 5,000 if you compare the training costs of the participants versus the control group. So you'd end up here with sort of what looks like already a sort of 5-to-1 benefit cost ratio. But if we take the marginal value of, public funds approach of Nathan and Ben, and think about this is where the government budget part of this is going to be a key input here. We're actually saving money on this program after 5 years. The increase in paid taxes outweigh the net program costs, and so there's about after 5 years about $11,000 gain for on the government budget. So this is going to translate into infinity, I believe, I take it, if we do the MVPF approach, because we're getting sort of benefits, substantial benefits by raising the earnings, to the participants, and we're on the net saving taxpayers' money. So relative to a traditional one, if you take this program out far enough as being observed, it's going to show up as an infinity on our marginal value, because we actually end up more than paying back the government expenditure through the higher taxes and lower transfer payments. And similarly, if you look at Year Up, it's a somewhat more expensive program. Here comes a somewhat trickier item in doing this. So Year Up, the earnings gains are about 22,000 through 5 years. The cost of the program, the total cost is 28,000. But how do I think about that and sort of the benefits of that cost? 11,000 is sort of the 6 months they're sort of staying in the program and getting real services from Year Up. So on this metric, on a benefit cost, it's going to look very good pretty quickly, and the extra revenue the government's getting is probably going to outweigh that. But the other question is, there's 17,000 that's covered by the employers providing the internships. Should I think of that as a cost of a program, or should I think they are getting some benefit? Why are for-profit employers, there's an issue, spending 17,000, to get these sort of interns? If I think there must be some benefit, they have some monopsony power, they have, they're getting some gain of goodwill or something, it's not clear how, and I like, how I think about that 17K that employers themselves are putting out voluntarily to attract these. So I view that, I'm going to view it as sort of 11K as the cost, because I'm going to assume the 17K is actually being offset in some way by the employers. That's, I think, an open question when part of a program uses private employers who are, undertaking costs in order to expand the program. So if we compare this to traditional job training programs of the type that my old report of the Department of Labor looked at, they tend to, looking at young, youth and young adults, have MVPFs, and this is from the QJ paper and off the website, more in the 0.2 for some of the more expensive programs like Job Corps and Job Start, to a little over 1 for some of the, Jobs Plus, slightly cheaper programs where we've had longer run earnings outcomes. The initial calculation for work advance that's on the website right now and is in the published paper only had a couple years of results, so that you weren't getting the big, it looked like 0.78. The refined one that sort of do 10-year projections, and you'd already be there at 5 years observed. So it generates the infinity because the earnings gains continue well beyond the first 2 years, and there are no more costs to the government. In fact, the government's saving money over that period. And I think for each one of these where we now have longer term follow-up and you forecast it, the numbers in the QJA paper understated the MVPFs substantially for these types of programs, because the earning gains in all the cases we've observed them seem to be sustained at least the same level, now out in the latest work advance 11 years with no evidence that they're sort of going down, and there are no further program expenditures. They're just higher earnings and greater tax receipts, lower sort of government expenditures on benefits. So if I take this relative to traditional training programs, they look really good in terms of the MVPFs. Hard to do better than infinity, I guess. And it also suggests that the sort of model here of targeting people who wouldn't have access to high wage jobs, improving their human capital and providing these services, looks like as good an investment as sort of early childhood education. I'm not saying we ought to trade it off, but the sort of Heckman notion that nothing is sort of beneficial after early ages in terms of human capital investments certainly seem belied, both by the high returns to expanding public college, such as Seth Zimmerman's work on Florida International University and some of the community college, and in the sort of sectoral employment training programs. Certainly some of the more traditional programs do look problematic in their MVPFs, which is why I think the shift towards this sort of model may make a lot of sense. So just to conclude, and then we can have sort of discussion. If we look at the mechanisms, it really seems to be that, and here we see it for work advance, there are big impacts of getting people into the sectors they're trained for. And while there's a $2,000 earnings impact in year 2, you're in occupations and industries with like 5,000, 3,000 to 4,000 higher earnings, and being in one of these higher wage occupation industries then predicts the faster earning, the higher earnings farther out. So my bottom line is that the key here is getting people into these high wage sectors and breaking down those barriers, and the training really does matter also where they don't have access to it, because in the first year of towards employment Madison strategies, we use the place them in the employers first and hope the employers will train them. And that actually had no payoff at all. The later cohorts, we moved to the employment model where we train them first and then have employers take them. And finally, the higher the wage sectors for which you place, the bigger the one sectoral employment training program with no long run earnings gains that seem persistent is this one in New York, St. Nick's, which train people in sectors that look not very different than the ones the control group gets. That is pesticides. Pest control isn't the future for high wage work of disadvantaged workers. So in conclusion, relative to traditional training programs, there is some hope that this new version has very high improvements for workers, breaks down barriers, and the MVPFs, I think when you look at a long enough horizon, look very promising. Some of the big open questions are something like Year Up has been scaled up from its initial Boston to many community colleges, and the national evaluation covered sort of a dozen cities. So it looks like scale up is possible, but is scale up possible if you start pushing it to people who might not pass the initial screens is a big open question. And is it possible, to learn more about some of the general equilibrium effects? Are they going to increase the gains by breaking down discriminatory barriers, or are there displacement effects of similar other workers are the big questions. So I'll leave it there. I know I went a little over.
Oh, that was wonderful. Thank you, Larry. And I guess I'll put a little bit of context on some of the things you were saying on kind of the referencing of the QJE paper of Ben and I, where one of the things we did in that work when looking at job training programs is if we observed impacts for a period of time, we didn't forecast any of the job training estimates forward. Whereas for some of the human capital policies targeting children, we were seeing in the data, there's these persistent effects, and we forecasted them forward. And we thought with the historical job training programs, it looks like, Job Corps and others, you've seen not very long persistent effects. But it's incredibly exciting to see that we were wrong on the lack of forecasting for some of those policies, and are certainly enjoying the revision in those estimates and some promising strategies here. So with that, I guess one of the questions that came up in the chat is from Rafael Parenka again, and asking, I think, about kind of private markets versus public, is a classic kind of question in the training space. Is really thinking about, and it almost relates to that 17K you were talking about as well, is to what extent do private firms kind of have an incentive to make these investments, or what do we think the main barriers are for that? And related to that, in terms of making these kinds of policies kind of the most effective from kind of a bang for the buck, is there really a needed public-private partnership like what the Europe strategies do, where they're partnering up with particular firms in order to get those high returns? And if so, is there something that the government has to set up in order to kind of reap those returns?
Yeah. So I think these are great questions. I think private firms do some training, but there's the extent that the skills are broader than the individual employer, that there is the poaching issue, that their wage is going to be bid up, that reduces their incentives, and if workers don't have the liquidity or the knowledge or information to do it, intermediaries and this partnership one at the sectoral level may be needed for a lot of valuable training. And I think that's the role that sectoral employment training programs play. Sometimes it's a community organization like Perescolas that delivers the training. Sometimes they partner with community colleges. So Project Quest works with the community colleges in San Antonio. Year Up curriculum is developed working with community colleges and actually gives college credit for community colleges. So I think the question is, with Year Up as a partner, an employer like State Street Bank or a tech company are willing to sort of invest. Our sense is, if you just send out the workers without the initial sort of training of these same people, they're not going to get the same opportunity without the intermediary. Maybe over time, they'll directly go to the high school where the kids came from, because now they're more confident. And there's a longer run question of whether recruitment practices will change. But it certainly, up to this point, it's really tough without the intermediary and the partnership role to get that sort of investment from a private employer.
That makes sense. A related question on that front is the extent to which individuals themselves, kind of related to what Amy was talking about, was sort of revealing kind of an individual's demand curve for Medicaid or for subsidized health insurance, kind of incorporating an idea of rationality in somebody's own willingness to pay. Do we think that in this kind of setting where people are just too liquidity constrained, where we wouldn't want to try to do that type of an approach? Are there approaches where people are asked to put in a little bit of money into the job training programs? And how should we think about kind of the private demand versus the other?
Right. Well, there's a growing, because these programs are sort of limited, there is a growing market of shared income payment approaches where money is not put up front, but if you do well enough ex post, you pay back. So we're actually, David Autor and Matt Noto are working with Pursuit, which is a high-end sectoral employment training that uses one of these shared in. And it's actually attracting a lot of capital. Social finance has been working with a number of providers. And I think what we would like is to combine strong evidence from sort of RCTs to, so both investors and, the participants, are basically pretty confident that what they're getting actually has a treatment effect. The worry of some of these shared payment contracts is a lot of cream skimming. I find workers are going to do well anyways. I give them training, it didn't actually do anything. And the RCT at least allows us to see if there's a treatment effect, or whether this is just, it creates big incentives for sort of cream skimming. And in fact, you're fooling people into paying for this program where they would have gotten the same gain otherwise. And so for programs like Perescolas and stuff, we clearly see evidence that there's a real treatment effect. But some of these, along with the shared income model, that's what we're trying to look at, whether they also have similar impacts.
That's exciting. It'll be fun to see those results. So then the last question from Fernando in the Q&A asks a question kind of related to what we were chatting about a second ago about how much of the change in the MVPFs for these kind of more recent sectoral training programs versus the earlier job training programs is the result of seeing estimates for a longer period of time versus a change in the actual type of program. And my instinct on this is that a lot of the old programs did have long run follow-ups that weren't nearly as strong as what we're seeing today, but I wanted to see if you were agreeing on that front or had any other additional thoughts on that.
Yeah, I think we are doing a better job of long-term follow-up, but I think much of it is that in fact, the earnings games have persisted much more for these new programs than in some of the early ones. So Job Corps, again, you can find, you can cherry pick. You could, if you look at the older individuals in the Job Corps, the earnings effects seem to have persisted. If you look at the overall one, it looks pretty bad. My guess is there's subgroups for which the Job Corps would potentially have the infinite MVPF, but I worry, that there were 8 ways of finding subgroups and stuff that's going to be tough to do. I mean, there were some other promising early programs that have never had long-term follow-up. The national supported work, we don't have the long-term follow-up. Some of that, and Hilary may know, I know that there are efforts by MDRC and others to try to link up, now with tax data, many of these earlier programs that looked promising to see how persistent. So some of those may be updated. The Job Corps has already been long-term follow-up, but the national supported work could end up, looking better with longer term follow-up.
Makes sense. All right. Well, we'll look forward to seeing more evidence in the future. All right. So thank you, Larry. That was wonderful. So I think now we'll go ahead and turn it over to Chris. We'll let you get your slides shared. So Christopher Walters is going to be presenting Augmenting State Capacity for Child Development, Experimental Evidence from India. So take it away, Chris.
All right, thanks, Nathan, and thanks to everyone for being here and for the opportunity to present. Hopefully you guys can see my slides. So this is joint work with Ale Ganimian, who I believe is here on the panel to answer all of your questions in the Q&A and the chat, as well as Karthik Muralidharan at UC San Diego. As you can see from the title here, this is a bit of a different context than some of the other work we've seen today. This is a project looking at a program in India. So among other things, it'll be a different government budget in the denominator of the MVPF, but I think some of the cost benefit issues that we encounter here, and in particular, questions about forecasting long run benefits are going to be relevant. So hopefully we can contribute to that discussion. So just to give some motivation, there's increasing policy interest, I think, in providing high quality early childhood education, or ECE, as we'll call it in this talk, in developing countries around the world. That's motivated by a couple of different considerations. First, the general body of evidence that early life interactions that children have with parents and teachers have important consequences for their long-run development and outcomes. And then, in addition, large social returns to some high-quality ECE interventions, as Nathan and Ben point out in their paper. And second, low learning levels despite progress in school enrollment. So in a lot of countries, there's been success in increasing school enrollment and completion rates, and yet learning levels by a lot of metrics remain low in those settings. So this creates some enthusiasm for early childhood education as a way to try to improve school readiness and maybe increase the productivity of these later educational investments in the system. In terms of what we know, there's some promising evidence on early childhood interventions in developing countries. I have some citations on that here. We'll have time to talk about that, but we don't know much about improving quality ECE at scale in developing countries. So this paper is meant to provide at least a little evidence on that question by evaluating the impact of an intervention that hired extra workers within India's Integrated Childhood Development Services, or ICDS program, which is the single largest early childhood program in the world. Okay, so just to provide some background on the setting and ICDS in particular, the ICDS program serves about 36 million kids between the ages of 3 and 6 each year, and disproportionately caters to poor children in India. Just for context, looking at the same age groups, ICDS is about 50 times the size of the US Head Start program, which many of us are familiar with. So this is quite a big program. It provides a range of different services, both free preschool education, as well as a bunch of other types of services, health and nutrition, for example. So kids who attend ICDS centers, they get meals while they're there. ICDS workers provide home visiting and nutrition education for families, a range of different types of services. Sorry, my computer is making noise. I don't know if that's interrupting what you guys are hearing or not. I'll just keep going.
We're good.
Okay. All right. Okay. So let me keep going. Services the primary kind of vehicle for ICDS services are Anganwadi preschool centers, or AWCs, as we'll call them in this project. These are preschool centers, public preschool centers staffed by usually two workers. First is a primary Anganwadi worker, or AWW, as we'll call it, who's responsible for the various health and education services provided by the center, as well as an Anganwadi helper, AWH, who assists the AWW and is responsible for doing things like preparing meals, feeding children, and the like. And despite its importance for reaching this kind of highly disadvantaged population of poor children, in India, ICDS faces some pretty significant resource limitations. In particular, salaries in the system for AWWs are much lower than those of civil service teachers in India, about a fifth of regular public school salaries. And the many responsibilities that AWWs have to deal with at the centers limit the time that they can devote to preschool education, which is meant to be one of their key roles. And in particular, in this scoping study that my co-authors conducted, found that only about 30 minutes per day was spent out of a scheduled 2 hours was spent on preschool education. Okay, so as a result of these considerations, we evaluated this facilitator intervention, which was meant to hire an extra worker exclusively devoted to teaching preschool education in Anganwadi centers in the state of Tamil Nadu in India. The way the intervention worked is that the government of Tamil Nadu offered the treatment group in our sample a one-time grant to hire an early childhood care and education, or ECE, facilitator. The facilitators were hired on 2-year contracts. The eligibility criteria for these positions were similar to AWWs. So they had to be female, at least 18 years old, residents of the local community, and a minimal education requirement. The facilitator provided 2 hours per day of preschool instruction, or at least was supposed to. I'll show you effects on time use later on, based on a curriculum developed jointly by the government and UNICEF. So this is the same type of instruction that the AWWs are typically providing. You should think of this intervention as essentially doing more of the same, trying to better fulfill the goals that the system already has through increased resources in the form of the facilitator. And the facilitators were paid around half the salary of an AWW. So they worked half the hours and were paid half the salary. The intervention here was implemented by the government within the ICDS system, using similar protocols to those that would be used, we think, if it were to be scaled up system-wide. So the experiment that we're using to evaluate this, we drew a stratified random sample of 320 preschool centers, AWCs, across 4 rural districts in Tamil Nadu, meant to be representative of a population of about 60 million people. We randomly assigned those 320 to 2 treatment arms. First, the control group, the treatment group, which received the rights to hire the facilitator, and the other 160 to the control group with no intervention. Randomization stratified by district, measure of whether the initial AWW position was vacant, and an index of local demographic characteristics. The combination of this representative sample of AWCs that we're looking at and the government's implementation of the program, we think makes this a kind of uniquely externally valid intervention. This is a point that Karthik has made in some of his other work. We're hopefully measuring treatment effect parameters that are very similar to what you'd expect to get if you actually implemented this on a much larger scale. So key outcomes for the study, we had sort of 2 sets of outcomes. Our primary outcomes are going to be test scores on math, reading, and executive function assessments that were specially designed and administered in the local language to try to measure skills for students in this population. There's a lot more on that in the paper. We also looked at some secondary outcomes related to child nutrition, in particular weight for age, or WAS scores, and height for age, HAS scores. So the purpose of the intervention was explicitly preschool instruction. So we thought we'd primarily see effects on test scores, but as you'll see, the availability of the facilitator frees up time for the main worker to focus on other tasks as well. So we studied these nutrition outcomes as a secondary set of outcomes. So we measured these things at baseline, which for our study was September to October 2016, and then again at end line, which was around March to April 2018, so an 18-month follow-up horizon. And we took those measurements in two locations. First, baseline and inline measurements at the AWC itself. So we went to the AWC, measured outcomes for all the children who were present. As you'll see in the data, a lot of students disappear from the AWC between baseline and end line, which is to be expected in the context that we're studying. We kind of anticipated that, and so also measured outcomes at end line for a random 50% of the sample in the household through household visits, which leads to much lower attrition rates. That's meant to address these attrition concerns. Additional data collection, we also did some surveys to assess implementation fidelity, and then visits to the AWCs to measure time use to see how the addition of the facilitator affected the day-to-day functioning of these preschool centers. Okay, let me get into the data. So summary stats at baseline. Column 1 is the control group, column 2 treatment, column 3 is the difference. Just a couple of points to make on this slide. First, this is a fairly disadvantaged population by observed measures of health and nutrition. For example, the average weight for age and height for age scores in the control group are about minus 1.5 standard deviations, well below common benchmarks for weight for age and height for age. And as a result, around a third of the sample is classified as severely or moderately underweight or stunted. Okay. Column 3, we see treatment control differences. Those are mostly close to zero, statistically insignificant. We have a little bit of a chance imbalance on age, but in general, we think the randomization worked pretty well to balance things. The other key concern here, as I alluded to on the previous slide, is attrition. So we have these two locations of the assessments, first in the preschool center itself, the AWC, and second in the household sample. In the AWC, we see no difference in follow-up rates between treatment and control, so that's encouraging, but the control overall follow-up rate is only 33%. And this reflects a combination of students aging out of preschool, leaving to go to private preschool centers, or just attending intermittently and not being picked up by the surveys. We were expecting that, so we also did these household measurements where we caught up with around 89% of the kids, and again, no difference in treatment and control follow-up rates there. So let me just show you briefly the treatment effects on outcomes before getting into the cost-benefit issues here. So this first set of results has to do with time use and time allocation. Just to start out, here we're looking at impacts of the intervention on the likelihood that the center is open at all. So what we see here is that the control centers were closed around 13% of the time when our unannounced visitors arrived to see what was going on. The treatment group was closed only 4% of the time, a difference of around 9 percentage points, which is quite large relative to the base control rate. You could have different ideas for the mechanisms here. One plausible mechanism is that the facilitator was supposed to arrive by 10 a.m. and the worker has to be there to let them into the building. And so it looks like what's happening is the workers are showing up at higher rates in the treatment group in order to let in this extra person that we hired. So there's sort of a complementarity in terms of time use between the two. What about what's going on inside the center itself? So there's a lot of numbers here. This is basically summarizing from our unannounced visits what people were doing during a 2-hour window that we observed the center. The facilitators were supposed to provide around 2 hours of preschool education. In practice, we saw them providing around 1 hour, with the rest of their time split between various kinds of administrative tasks, health and nutrition tasks, some absences, and off-duty observations. The presence of the facilitator also affected what the regular worker, the AWW, was doing. We see AWWs in the control group were providing about 38 minutes per day of preschool instruction out of the scheduled 2 hours. That actually fell by 19 minutes in the treatment group. So some of the extra time is being used for other things. Of course, combining the preschool instruction from both the facilitator and the AWW, there's a huge increase in total time devoted to instruction of about 38 minutes. That's like doubling this control rate. What does the worker do with the extra time? A mix of things, increases in kind of all the observed task categories that we can measure, both time spent on administrative tasks, health and nutrition related tasks, and also some extra time spent off duty. So it looks like this increased the slack in the system a little bit, but overall, taking the combination of the two workers, we see big increases in kind of all these composite measures of time use across the major categories of activities that the workers are meant to be engaged in. Okay, what about child outcomes? So maybe not surprisingly, given that we saw these big increases in preschool instruction, but we see fairly large impacts on test scores for students. Panel A here is the AWC assessment. So this you could think of as the students who are still at the center 18 months later, so a more high attachment sample of kids. And we see quite large test score impacts in that population, 0.29 standard deviations in math, 4.6 in language, 0.18 in executive function. This composite score is first principal component, kind of an index combining all three of these, and that's a gain of 0.29 sigma. Pretty big effect. Panel B, the household assessment, shows effects pointing in the same direction, also significant, but smaller, as you might expect, because 2/3 of these kids were no longer at the center 18 months at end line, 18 months after baseline. Composite score effect of around 11% of a standard deviation. If you scale that by the difference in attendance rates, so only around 1/3 of this group was still exposed to the treatment, you actually get a number that's quite similar to this. So you might think of this as kind of a intent to treat style impact for all the kids who were present at baseline. And this is sort of the treatment effect for the kids who received high exposure as measured by their presence at end line. Okay, and consistent with that, we also look at the subsample of kids who were present in both, so who showed up both at the AWC and who were measured in the household. And we see very similar impacts on both the AWC and household assessments for those for that group. So this isn't something to do with differences in measurements in the household versus the AWC. It looks like it's a difference in population. In particular, these kids who are still there 18 months later are getting the big benefits. Finally, what about nutrition? So, full disclosure, our pre-analysis plan said nutrition was a secondary outcome for the study because we expected most of the impacts to be on test scores. But it turns out that in the high exposure AWC sample, we actually see some pretty significant impacts on measures of child nutrition. Around a 1/10 of a standard deviation increase in weight for age scores and height for age scores, reductions in the fractions of students that are severely underweight or severely stunted, meaning WAS or HAS below -3 sigma, below the mean. Okay. And as before, the household measurements kind of point in the same direction. So positive estimates on WAS and HAS, negative estimates for fraction underweight or stunted, but nothing significant there in the household sample. All right, so those are the basic treatment effects. And then I want to spend kind of the remainder of the time on thinking about cost effectiveness. So how should we value the short run impacts of this intervention that we measured through this RCT? We take two approaches to doing this in the paper. The first approach is to try to actually assign some kind of economic value to the short run test score impacts that we see and use that to calculate an explicit benefit cost metric like the MVPF for the program under some assumptions. So the basic problem that we encounter here, which is not unique to us, it basically plagues all short run evaluations of early childhood education programs, is how should we value short-term impacts of these programs without data on long-term outcomes? to do a comprehensive cost benefit analysis of the program, we'd like to see things like crime, education, earnings in the long run. But we don't see that since this was implemented just a couple of years ago. So we have to make decisions based on the short-term treatment effects. The approach we take in the paper is pretty simple. It's to just try to predict impacts on the longer run stuff that we wish we saw, in particular adult earnings, based on estimates from other sources linking short-term test score effects to earnings gains. So I'll show you that. As always, there's significant uncertainty in that mapping. So I can't be sure that in Tamil Nadu, the relationship between test score effects and earnings effects is going to look anything like it looked in other settings. And among other things, this could also understate gains mediated by non-cognitive outcomes, a point that Jácome and co-authors made in some recent work. But another way to look at this is that some kind of strong assumption of this type is required if I'm going to evaluate any ECE program within a policy relevant timeframe. An unfortunate fact of life is that all decisions, including policy decisions, are made in the present without the benefit of hindsight. So I can't wait 25 years to look at impacts on earnings to decide whether I should expand the program. Now we have to make some assumptions to do that. So this is one kind of framework for thinking about doing that. A second approach that we take in the paper, which tries to get around some of these strong assumptions, is to instead compare the effects of this program to impacts of a realistic alternative policy that might actually be implemented by the government. In particular, in this setting, historically, increases in funding for the ICDS program are often used for across-the-board increases in worker pay. And in a companion paper referenced here, we conducted a randomized evaluation of an intervention like that, an across-the-board pay increase in the same population of AWCs that we studied for this facilitator intervention. So you might think it's useful from a cost effectiveness perspective to evaluate both of these interventions on their own terms in the short run, comparing short-term treatment effects and trying to sidestep some of the assumptions you'd need to calculate an overall benefit cost metric. If I'm just trying to decide which of these two things should I do, I don't need the overall MVPF. I just have to decide which of the two MVPFs is bigger, and that can guide my decision making. Okay, so let me show you some results from both of those approaches. First, this kind of prediction approach. A simple way of setting this up is to say, well, let's try to construct a benefit cost ratio based on predicted benefits on adult earnings. And let's suppose that the treatment effect on adult earnings, call that DY, so that's the effect of the program on the PDV of earnings for the kids who participate as a proportion of their earnings, is the test score impact scaled by some conversion factor P that converts test score effects to earnings effects. Okay, so the thing that we can measure from the experiment is this DT object, the change in test scores associated with implementing the intervention. To turn this into a predicted impact on earnings, I need to both predict Y, the denominator of that proportion, and then calibrate this P. So how should I translate a short-term test score impact into a projected impact on earnings? In other words, what economic value should I assign to test score impacts at age 4, say? Okay, so first part of that predicting earnings. This is probably the less exciting part of this calculation. We calibrate some things from a few different sources and come up with an estimate of around 3 million rupees. So something like 30K US dollars for PDV of lifetime earnings for kids in this rural Tamil Nadu population that we're studying. So this is sort of calibrated from various sources. We think that's a rough estimate of what these children might expect to earn over their careers on average. What about the second part? So how should I assign an economic value to short-term test score gains? This is a table from some previous work that I did with Pat Klein, trying to do this same type of approach for Head Start. In this table, we essentially assembled all the estimates we could find from interventions that reported both a test score impact in the short run and either an earnings or wage impact in the long run, and then kind of calculated the ratio of those two things in this last column, which you could think of as a study-specific measure of what the right P would have been to calculate the earnings impact if I had applied it to the short-term impact of each intervention. And you can see these are all positive. Unfortunately, all the studies that I have in this table are basically coming from developing countries. So it turns out that we don't know much about this mapping for the developing world. These are all from the US or other developed countries. But if we just look across these different studies, we see that in general, it looks like earnings gains are, test score gains translate into earnings gains at a rate of 10% per standard deviation or more across a wide variety of different settings. So we kind of take an estimate that's in the middle of this range from work by Raj Chetty and co-authors, 13%. Okay, but I'll show you a sensitivity analysis on this also, because it's obviously not clear what the right number is to use. But suppose we take that 13%. We have this 3,300,000 PDV of earnings. We measured for the household sample, which was the full sample of children present at baseline, a 0.11 standard deviation test score impact. Multiply that by this 13% conversion factor times this 3.3 million, and you get a predicted earnings gain per child of around 50K or 50,000 rupees. Okay. There are 14 kids per center per year in our sample. We ran this for 18 months, so that actually understates the total number of children served by the program by about 33%, because there's a second cohort that came in the second year that we didn't include in the sample. So multiply these numbers together, you get a kind of aggregate benefit per AWC of something like 880,000 rupees. The first order fact about the costs of this program are that it's quite cheap. So as I mentioned in the introduction, AWWs are only paid around 1/5 of what civil service teachers are paid in India. And then the facilitator that we hired as part of this intervention was paid about half of that. So a total cost over 18 months of around 75,000 rupees per center, which is pretty low. Simple benefit cost ratio just takes the ratio of those two numbers, which is something like 12. So if you buy this projected earnings impact, then the present discounted value increase in earnings generated by the program would be something like 12 times the contemporaneous cost of implementing it. Of course, this relies on a ton of different assumptions. So we do some sensitivity analysis on this, varying all of the parameters in that calculation across a range of values. And the bottom line of that is it's pretty hard to get a low cost benefit cost ratio for this program, primarily because the intervention is just very cheap. So you have to assign a pretty small value to the test score impacts to not arrive at a high benefit cost ratio. This is kind of a distribution of estimates that we constructed by drawing parameter values from various supports. But the bottom line is that the lower bound of the support of this is actually pretty high. Fifth percentile is like 4. Okay. We also in the paper do some analysis that tries to incorporate the nutrition gains that we found for the AWC sample, which as you'd expect leads to larger benefit cost ratios, getting it up there around 16 to 20, but I'll skip that for today. And talk a little bit about MVPF. So Nathan's going to get mad at me for taking benefit cost ratios like I did on that last slide. How should I think about the MVPF for this program? A simple way to do this is to say, well, maybe we should just think, if I'm thinking about the willingness to pay, which needs to go in the denominator of my MVPF, if I take that to be the change in net PDV of earnings, ignoring any other benefits that accrue through other types of channels, and I assume that children in the sample are going to pay an average tax rate of tau, then they end up with 1 minus tau dy at the end of the day from having been part of the program. And then the government spends the program cost C minus tau dy because it gets back tau dy in terms of future tax revenues. And what you can see from that is the program pays for itself, meaning as Larry found for job training programs, MVPF of infinity, if this denominator is negative. So if there's a negative net impact on the government budget constraint. And that happens if the tax rate is big enough, in particular, if it's bigger than C over dy, which in our benchmark calibration would happen as long as tau is at least 8.4%. Because the program is relatively cheap, you don't need a very big net tax or net tax rate for the children involved to arrive at an infinite MVPF forecast for the program. Although income taxes are rare in India, This seems likely to be satisfied. For example, the goods and services tax covers most of the economy at rates of 12 to 18%. So you might expect the government to get back at least 8% of any increased earnings through that tax. Okay, so if you buy all those calculations, our benchmark would suggest that as long as you're willing to assign a tax rate of at least 8.4%, you're going to get an infinite MVPF out of this program as well, which maybe that's surprising, but on the other hand, Nathan and Ben's paper documents pretty high estimated MVPFs for a lot of historical ECE interventions in the US, many paying for themselves in this sense. And one way to interpret our results is it looks like similar returns like that could be possible for contemporary ECE interventions in India in the present day, at least by the calibrations that we've done here. Okay, in my last few minutes, let me just talk a little bit about this alternative cost-benefit approach. So you might not be happy with all the strong assumptions I had to make to forecast an MVPF for an early childhood intervention where I can only measure short-run test score impacts. So a practical alternative to that is to just compare the effects of this program to whatever the likely alternative is in terms of ICDS use of funds, if it gets a funding increase. To decide between two particular alternatives, I just need to know which of the two MVPFs is higher. And that allows me to remain agnostic on a lot of the unknowns in that formula, as long as I assume that the errors that I make affect both programs equally. So maybe I get the calibration linking short-term and long-term impacts wrong, but as long as my error there is sort of affecting both programs equally, maybe that's okay. And a comparison of short-term impacts is still the policy relevant treatment effect comparison. As I mentioned earlier, since 1975, ICDS has typically used increases in its funding for across the board pay increases. So that represents a kind of plausible business as usual counterfactual use of funds that the government might do instead. In this other paper, we reported the impacts of that exact interventions in the same population of preschool centers in the experiment I'm summarizing today. So we can compare treatment effects and bang for the buck, meaning impact scaled by cost for these two interventions. So this table is taking a kind of pass at that. We have the treatment effects on test scores for the household sample and the AWC sample that I showed you before in the first two columns, top row here. The short answer on the across the board pay increase is that it basically didn't produce much in the way of measurable benefits. The overall impact for the household sample was slightly negative and statistically insignificant. We actually got a marginally significant negative for the AWC sample, which maybe is a little bit surprising. But for the purposes of evaluating this intervention, which is the focus of today's paper, we just want to know which of these two things is bigger. And in both cases, we can reject equality of treatment effects. So it looks like the ECE facilitator is producing significantly larger impacts than this across the board pay increase. You might say that I should scale that by cost. That's what we've done in columns 3 and 4 here. The facilitator was a little bit more expensive than the across the board pay increase, actually. The units here, this is basically saying, suppose I put these treatment effects in units of hundreds of thousands of rupees spent per child. If I spend 100,000 rupees, I get back in the ECE facilitator intervention on average 2 standard deviations of student test scores. That turns out to be almost exactly the same in the household and AWC samples. That's a consequence of the fact that the sample sizes and treatment effects scale exactly in proportion based on that calculation that I mentioned earlier. For the across the board pay increase, I'm dividing these negative numbers by cost. Those are still negative. And at least for the AWC sample, we can reject that the bang for the buck here is the same for the two. Okay, so I think I'm basically out of time. So let me stop here. The point of this paper is to study impacts of hiring an extra worker focused on early childhood education within the ICDS system. And we ran this RCT, which showed large increases in time spent on education and health and corresponding improvements in test scores, as well as some improvements in nutrition for this high exposure sample of kids who were still enrolled at the preschool center 18 months later. From an academic literature perspective, the results here, I think, provide some new evidence on the efficacy of increased educational resources in a developing country context. So we have a lot of evidence on the impacts of things like class size reductions, increases in instructional expenditures, things like that. This is sort of showing that increased resources in the form of additional staff hired at preschool centers leads to pretty big increases in academic achievement and some nutrition gains as well. And as best we can tell, the intervention appears to be pretty highly cost effective, both measured relative in terms of projected benefits relative to cost, and in terms of treatment effects relative to another realistic use of ICDS funds in the form of this across the board pay increase. Okay, so I'll just stop there and ask if there's any questions.
Wonderful. Thank you, Chris. So let folks feel free to ask your questions in the Q&A box, but I guess I'll start with kind of thinking about the difference between the two approaches that you propose. You know, kind of if you can, obviously forecasts are hard, you know, as we were discussing with Larry's paper a second ago, and the work that Ben and I did, you know, when we just did a short run effect and tried to think about, geez, do we need to forecast this thing? And I think we're ready to admit that we should have forecasted, but didn't. It's hard to know kind of when to do that and when to not. And if you have kind of an intermediate variable, like you mentioned, that you can all just focus on, that then we can just do kind of a cost effectiveness analysis for that particular intermediate variable. I guess I'm wondering in your particular context, so that's going to rely on, you have two policies, they affect an intermediate variable. We really care about the long run outcome. There can't be differential channels to the long run outcome as opposed to what's in through the intermediate outcome. And I'm just curious, I'm sure this is something you've thought about, how you're thinking about that in your particular context, or perhaps even another context, to think about that particular approach for helping solve this kind of extrapolation problem that we all face.
Yeah, that's a great question. I think in the particular context that we're studying in this paper, you could plausibly see the comparison based just on test scores as kind of a lower bound on the difference in effectiveness between the facilitator and the across the board intervention, in the sense that we ignored the nutrition benefits. And I didn't show you this, but we didn't find much in the way of nutrition benefits for the across the board increase either. So it looks like on kind of the two domains we can measure, the facilitator is having bigger impacts. So I think what you would need in general for that to work is kind of the assumption that there's no outcomes you care about operating in the other direction. So as long as you think the ordering is kind of the same on all the stuff you don't see, it's probably okay to focus on one or two.
Yeah, basically you're imagining that kind of there's generally correlated effects. When programs work, they tend to work on a wide range of dimensions, and when they don't work on a wide range of dimensions. And that's
I think that you'd be most concerned about that issue if you had two programs that were targeting explicitly different types of outcomes, like a nutrition focused intervention and an education focused intervention. I think the across the board intervention is kind of an omnibus, like overall attempt to increase the quality of everything. So it's not directed in the same way. The facilitator was explicitly aiming to improve learning outcomes. So it is kind of directed, but we also, it turned out, saw these nutrition benefits as well.
That makes sense. Anybody else like to ask a question? So I'll ask one more on the income tax question, which I think is crucial in the kind of developing country contexts, because I think part of what makes the kind of MVPF approach differ from the traditional cost benefit, as you were showing, is kind of what tax rate you apply to these different things. And obviously, if there was just purely no completely informal economy, there'd be no difference between a kind of traditional benefit cost ratio and an MVPF. And I actually didn't realize that you could think of tax rates as high as 18% in India. And I'm curious if that's just kind of on paper, or how I think about the informal economy kind of interacting with that that tax rate.
Yeah, that's a good question. I mean, that referred to the goods and services tax, which has different tax rates for different types of things. So 18% is kind of on the high end of that. It's more like a consumption type tax than an income tax. So there's some slippage between income and consumption, of course. Okay. But I think it's at least plausible to think that 8 to 10% of this could be clawed back through the consumption tax.
Yeah. Okay. Cool. Well, thanks. All right, so I guess we can move on to the next paper and come back to the US and talk about food stamps. And so we'll let Hilary get her slides pulled together. So we're going to have Hilary Hoynes presenting on is the social safety net a long-term investment, large-scale evidence from the food stamps program. And I believe you have a couple of collaborators as well that have joined, Martha Bailey and Maya Rawson-Slater, also available to answer any questions that come up along the way.
Thanks for that. Thanks so much for including our paper in this awesome inaugural conference. Really happy to be here. So I'm going to be talking to you about the long run effects of the food stamp program and whether or not we can think about the social safety net as an investment. And as Nathan mentioned, my co-authors Martha Bailey and Maya Rawson-Slater are here on the Zoom, and it's also joint with Reed Walker. And the disclosure, any opinions and conclusions expressed herein are those of us, the authors, and do not necessarily represent the views of the US Census Bureau, where we were lucky enough to do this work. So thank you. Okay, so, very much following up on what Chris just presented, I think for some time, the marginal value of public funds or other kinds of cost benefit frameworks are very commonly applied to human capital programs, such as preschool or what Larry was talking about in terms of the work advance programs. In that framework, all the costs are borne up front for the preschool, for the training programs, and the benefits may take some time to emerge, particularly in thinking about early childhood investments, such as Chris was just talking about. And interestingly, I think until recently, that is not a framework that's been applied to sort of general income support in the United States or potentially other countries. So what we're trying to do is to add to that evidence-based. Sorry, I just got a message that says sharing is paused. Do you guys still see my screen?
We do, yeah.
Okay, I'm just gonna ignore that.
We're on the first slide. I don't know if you tried to switch slides.
Oh, interesting. I don't know. I have switched slides. Don't know why that is. Let me try. Thanks for that. Try it. Maybe I'll just keep it in this mode. I'm using a different computer than normal. I assume you see it advancing now. It seems to be something having to do when I was in full screen. Okay, so our paper kind of gets at two questions. Does providing more assistance, particularly when children are young, lead to changes in their life trajectory? And does age of exposure matter? And we're going to study that problem within the context of the historical rollout of the food stamp program. So sort of the overall approach that we take in the paper is to use the historical rollout of the food stamp program, which took place across counties in the United States over about a 15-year period during the kind of Great Society period between 1961 and 1975. And what we've done is we've pulled together a combination of survey data and administrative data in order to examine the effects on children in the long run. And so we have the long form 1 in 6 sample from the 2000 census, which represents about 17% of the US population, as well as all of the American community surveys listed here. And those data through the Census Bureau have been merged with the Social Security numinant file, which gives population level information on county of birth, date of birth, and if deceased, date of death. And so we take this linked survey administrative data source on ultimately our sample of 17.5 million observations to examine sort of comprehensively outcomes for the rollout of food stamps on adult well-being. And we look at outcomes across human capital outcomes, economic, some disability measures, as well as information about where folks are living to get a sense of what we call neighborhood quality, as well as mortality through the numinant data and incarceration to evaluate effects on adult well-being. And then we use this to pull together an estimate of the marginal value of public funds of this program. So to start out, just a quick summary of the food stamp program and something about the rollout of the program. So sitting today, the program is now called the Supplemental Nutrition Assistance Program. Just pre-COVID served about 36 million people or 18 million households at a cost of about $60 billion. Households receive on average about $250 per month per household. Or if you think about it this way, the food stamp benefit averages about $4 per person per day. It is a targeted means-tested program. So eligibility requires that net income is below the poverty level or gross income below 130% of the poverty level. And the benefits are phased out in the sort of typical income support targeted model here in food stamps at a 30% rate, 30 cents on the dollar. And food stamp benefits, which are now back in our period of the rollout of food stamps, there was actually a paper voucher. Today, all the transactions take place on EBT cards. But both then and now, food stamp benefits take the form of vouchers in the sense that it allows individuals to purchase food items in grocery stores. So not toilet paper, not diapers, but food, frozen food, fresh food, canned food, healthy food, unhealthy food, just food, like we all buy at the grocery store. So stepping back, given our focus on children, and from the standpoint of where we sit today, the food stamp program after the tax credits is the second largest anti-poverty program for children in America. So taking a figure from the National Academy of Sciences Roadmap to Reducing Poverty, which uses data for 2015, shows that eliminating food stamps with no changes to behavior, just a mechanical calculation, would increase the poverty rate for children by 5.2 percentage points off a base of 13. So it lifts a lot of children out of poverty in the United States. So with respect to its historical origins, the food stamp program started in 1961 through an executive order by President Kennedy, who established sort of pilot programs across 8 different counties, and subsequently expanded to about 43 counties in the original pilot phase of the program. And these were very sort of non-random places. They tended to be very disadvantaged counties in the United States, including some Native American reservations, and also some counties in Appalachia, and also the city of Detroit, the county city of Detroit. So this then led to the 1964 Food Stamp Act, was sort of the beginning of the national rollout of the program. And in between 1964 and 1975 is the period under which we saw the program being rolled out across counties in the United States. And so in the end, what we see is food stamps arriving in some places as early as 1961, and in other places arriving as late as 1975. And while this kind of historical rollout turned out to be a feature of many of the programs during the Great Society period, the war on poverty, in practice, the programs evolved quite independently from one another. And Martha has done a lot of work that sort of shows that these things are not happening at the same time. And there's more work in the paper about that to sort of document that fact. But this is what the rollout looks like across counties in the United States. So the lighter shaded areas are the areas that implemented earlier, and the darker shaded areas later across the United States. And you see that there's quite a lot of variation in most states, quite a lot of variation within states, as well as variation across states. And it doesn't really follow your typical pattern that one might think about in terms of, New England and the upper Midwest being areas that had been historically more taking action towards anti-poverty programs early in our history in the United States. There's a kind of complicated story around the goals of the farm lobby versus the lobbying for poor families that ultimately led to the pattern that we see across the United States. So there is a lot of research that looks at to kind of get back to that conversation at the end of Chris's paper. We know a lot about how SNAP affects children in the short run. We know that as I just showed you, that SNAP increases families after tax and transfer income. There is an impact, disincentive of the kind of standard benefit and tax that you see in the food stamp program that reduces labor supply. But net of that labor supply effect, there's a substantial increase in after tax and transfer income. We know that families spend that additional benefit primarily and not solely on food. And food stamps has been shown to reduce food insecurity, improve health outcomes, improve some short to medium run child health outcomes. And we know that many families spend their food stamp benefit month after month before the end of the monthly cycle. So these are a set of findings that we have already demonstrated in the literature on the short run effects of the food stamp program. We also know that the social safety net has been shown in other settings to have large effects on long run outcomes through work on cash welfare, the earned income tax credit, Medicaid, getting back a little bit to some of the work at the beginning of the talk today, as well as Head Start and public housing. The previous work specifically on the food stamp program, myself, along with Doug Almond and Diane Schanzenbach, have a paper that uses the panel study of income dynamics and a similar rollout design, and shows that exposure to food stamps, particularly in the early years of childhood, leads to a quite significant reduction in adult metabolic health outcomes, obesity, high blood pressure, diabetes, and so on. Bittler and Fajinski used administrative data on earnings from the Social Security Administration's continuous work history sample, which is a 1% of the US born population, and find that exposure to food stamps before age 5 leads to increases in adult earnings for women with no impact on employment. So what do we contribute to this evidence? Essentially 2 things, or maybe 3. The first is that we sort of broaden the set of outcomes that we look at, from human capital to economic well-being, the neighborhood outcomes, as I mentioned, mortality, incarceration. We do so for a very large sample of this linked survey administrative data. And then, of course, on target for today's conversation, we put it together to estimate the marginal value of public funds. So I think in the interest of time, I probably said enough about the data in the introduction. So I will move on to say that we take that large linked survey administrative data and we limit the sample to those individuals who were born in the United States between 1950 and 1980 in order to get cohorts of folks that were, before, during, and after the food stamp rollout. And we look at ages 25 to 54 in looking at these labor market outcomes to make sure that folks are in the labor market and they're not moving into retirement. That leads us to a sample of 17.5 million observations. We collapse that data down to cells based on birth county, birth year, sometimes also birth month, and survey year, whether we're looking at the census data or which of the ACS samples. We also look at subgroups based on gender and race. And just, 2 sort of limitations or caveats of the analysis. One is that we don't know anything about the family other than where you were born and when you were born. So we don't know among our sample that we observed in the 2000 census, which folks grew up in poor families versus those that did not. So I'm going to show you estimates that are sort of a large intent to treat estimate. And then we use participation rates, population level participation rates in the program to adjust to a treatment on the treated estimate. The other thing to point out is, even though this is, clearly a historical exercise, taking a different approach than what Chris was talking about, we are trying to, have a long enough time frame to estimate these long run impacts, but still, our cohorts are still relatively young. So our youngest birth cohort at 1980 is 33 by the end of our sample period. And that's probably less relevant for the effects on earnings, but probably quite a bit more relevant for thinking about the effects on mortality and life expectancy, given that folks are still fairly young. So what we do with this data is construct 4 different standardized indices and also a composite index that combines across these 4 different indices. And we've put them into domains. So there's a human capital or productivity measure, which accounts for years of schooling, level of schooling, whether or not you have a professional degree, and what kind of occupation you have. Then we have a long list of kind of standard economic self-sufficiency. Are you working? How many weeks did you work last year? What is your income? Are you in poverty? Are you receiving income support, and so on? And then we use the information in the census, both things like a survey response, like, are you a homeowner? But then also we use census tract or county of residence that we get in the restricted data to also calculate area level characteristics, like the teen pregnancy rate in your area, the share of female-headed households in your census tract, and so on, to characterize both the quality of the neighborhood that individuals are living in, as well as what we can measure about the quality of their living environment, like, do they own a home and what is the value of that home? And then finally, for a subset of the sample, we observe information on disability, work disability. And I'm not going to talk about that much in the talk. We don't ever find anything very precisely estimated zeros on disability. In each of these, we calculate a standardized index where we use our, we don't have a RCT, so we don't have an untreated cohort. But what we do is we use the sort of older age in our cohort sample who's untreated, and we use their mean and standard deviation in order to create the indices of the 4 different outcomes. And then in addition to the 4 sets of indices, we measure separately a survival to the end of the period or life expectancy, as well as using a subset of the years from the ACS, where we have the group Porter's variable, we can assign an incarceration or a dummy for not being incarcerated at the time of the survey. So we pull all of this information together and in essence use a difference in difference design across counties and across birth year and sometimes birth month in order to capture this rollout of the food stamp program. So using the numinant file, we both know where individuals were born and when they were born, which allows us to assign the age at which the food stamp program was rolled out in their county. And we call that, their exposure age, the age at which food stamps first became available. And so we use both event study models, a kind of summary exposure model, and a kind of spline model in order to, but all within this difference in difference approach, in order to capture the relationship between when food stamps was first introduced in your county and your outcomes in the long run. And so in our event study model, the key fixed effects that we control for are the fixed effects of your birth county, the fixed effects of your year of birth, as well as a full set of birth state times birth year fixed effects, which absorbs a lot about the underlying policy and economic environment in the place that individuals were born. We also have some some robustness tests. We add the available data that we have that controls for policies and economic outcomes for the counties for these same cohorts in some robustness tests. We also are going to show you some results from what we call the summary exposure model, which is like the diff and diff version of the event study, which differs only from a standard diff and diff in that our main treatment variable is the share of time between conception, simply measured as 9 months prior to birth, and age 5, that food stamps was available in your county of birth. And you're going to see from our event study why we chose that specification, why that seems like a natural specification to use. So let me show you, just spend a few minutes on one event study outcome, and then I'll just sort of zoom back and talk about results more broadly. So this is the event study estimates for our composite index, which we kind of pre-specified as the model that we would do a lot of our testing of the robustness to different specifications. And I should point out that we set the omitted year in the event study at age 10. So this looks different from most event studies you would see. Usually we've got time on the x-axis of when a policy is put in place. The reason why we don't do that is that we would have to take a stand on at what age the individual was in order to measure that time. So instead, what we decided to do was just use the age at which food stamps was implemented as the event time. And so here you can see on this graph, as you move towards the origin, left on the x-axis, individuals were plotting the effect on the composite index for gaining access to food stamps 1 year earlier, and another year earlier, and another year earlier in their childhood, relative to age 10. And so there are three things that I'd like you to kind of get from this estimate. The first thing that you can see is that in later childhood, you can see that having access to more food stamps earlier, so at age 15 versus age 10, doesn't lead to much difference in outcomes in the long run. But somewhere around age 5, in that sort of just around the school entering age, you start to see a slope, an upward slope on the event study graph. And what that shows is that having access to food stamps a year earlier in your childhood at age 4 or age 3 or age 2 or age 1 or all the way back to conception leads to a kind of remarkably linear improvement in this composite outcome in adulthood. So that's the second thing you see. And then the third thing you see is that the event study flattens back out again at ages that are negative. And so that's kind of like the equivalent of, we call it the pre-birth or preconception pre-trend test. And so if this is food stamps and not something else going on in the county, we wouldn't expect it to make a difference if food stamps was in place 5 years before you were born or 3 years before you were born. You're fully treated regardless. So the fact that this flattens out is actually pretty strong evidence about this capturing food stamps, not something else. So that's the qualitative findings of the event study. You can get more easily to the quantitative findings of that event study by looking at this composite index exposure model, where we have the percent of time between conception and age 5 that food stamps was in place. And so if you just look at the third column with all the fixed effects in it, you'll see that having full access to food stamps between conception and age 5 improves your composite outcome, which, hold on just a second, I'll try to make more sense about the magnitudes here. But it increases the composite outcome in adulthood by 0.009 standard deviations. That's the intent to treat estimate. And if you divide by the historical food stamp participation rate for children at this time, which was 16%, you get a 0.06 standard deviation improvement in the composite index. We can then start to learn more by breaking that composite income index down into its components. And so here you can see the event study for the human capital index, economic self-sufficiency, and neighborhood quality, which we forced them all on the same scale to try to just see the magnitudes. And you can see larger effects for human capital than economic self-sufficiency, and similarly large effects for neighborhood quality. And you also tend to see the pattern of flat, increase, flat that you sort of see qualitatively across these different outcomes. And if you want to, say something more about the magnitudes, still in standard deviation units, we find that, again, exposure to food stamps from conception to age 5 leads to a 0.06 standard deviation treatment on the treated effect on human capital, a 0.03 standard deviation for economic self-sufficiency, a 0.07 standard deviation increase for neighborhood quality. For survival, to the last period that we observe in the data, is a 0.4 percentage point treatment on the treated effect, which is 11% relative to the mean, which most people survive to this age. So the mean non-survival rate is 0.04. And a 0.5 percentage point treatment on the treated effect increase in not being incarcerated. So just one more set of estimates, and then I'm going to turn to the marginal value of public funds. I'm not going to go over all these numbers. The purpose of this is to give you an idea that these treatment effects are quite consistently taking place within the components of these indices. And so you can see increases sort of across the board in human capital, although a zero effect on food stamps having an impact on a graduate degree or more. And I should say that all of these estimates are all in standard deviation units, just to put them on the same scale and thinking about them this way. You can see for economic self-sufficiency, actually breaking down the index gives us some more information. So there's no evidence that food stamps affects the extensive margin of labor supply. There's no effect on being in the labor force or working, but it does increase logged labor income. So it seems to be affecting more wages and maybe a little bit hours, but not working or not working. You also see improvements in not being in poverty and being less likely to be on income support. And so you can kind of get a sense of what's happening when you look within these indices. You can also see quite consistent effects across neighborhood quality, increases in home ownership, as well as kind of widespread improvement in the characteristics of the either census tract or county that individuals live in, and no effect on disability. And these numbers just kind of turn these into just percent effects as opposed to the standard deviation impact. So just to say one number that'll be very important for the marginal value of public funds, we find that exposure from conception to age 5 has a 7% increase in earnings in adulthood, treatment on the treated. So very quickly, we find that there's some heterogeneity in these effects across groups. So in particular, we find the effects on earnings and human capital much more for white rather than non-white participants, and more for men, for human capital, than women. For life expectancy and incarceration, we see the effects more concentrated for non-whites. And you can see that in the paper. So, of course, this is a quasi-experimental paper with the historical rollout of a program. We did a lot in the paper, and I direct you to it to try to convince ourselves that this was food stamps and not something else. We've got balance tests, we've got controlling for potential confounders, and for the most part, the results are quite consistent across the different robustness tests that we do. So what does this imply about the marginal value of public funds? So, given all the great conversations so far, I can sort of move towards how we do the implementation. But of course, the marginal value of public funds, we've got the numerator, which is going to represent the willingness to pay among families with young children. I should point out, and I was thinking about this as I was watching the earlier talks, all of the things I'm about ready to show you are calculations for our exposure model that focuses on exposure between conception and age 5. So in estimates and models that I didn't show you, if we go to that exposure model and then add another variable, which is the percent of time between age 6 and age 18 that you have exposure to food stamps, that adds nothing to your long run outcomes after you've already controlled for the early life. So our strategy here for the marginal value of public funds is to target it on the effects on the younger children. So the punchline is our marginal value of public funds in the paper is 56, not infinite, not 2, but a big number, I think. So how do we get there? So starting with the willingness to pay for $1 of food stamps, we're gonna have all the measures be per dollar of food stamps distributed to the household. The first thing we have to do is sort of make the adjustment that $1 of food stamps isn't necessarily the same as $1 of cash. And so using results from the literature, we convert that to 80 cents on the dollar. Then the pieces in blue are what come out of our paper. We then quantify two different aspects of the willingness to pay, that in terms of the higher lifetime earnings, and then also due to the higher life expectancy. And if you look at these estimates, so, we've got to do a lot of calculations under the hood because we have a snapshot of individuals' earnings in adulthood, and we need to project that out through adulthood to get the PDV of those earnings increases. And at the end of the day, what we have there is a willingness to pay of 45 cents for every dollar of food stamps. So that's the benefit to the household of those higher lifetime earnings. We also quantify the value to the household of the higher life expectancy. And you can see that doing that results in a willingness to pay of $55 per dollar of food stamps. So it's very clear when you break it up this way that our large marginal value public funds is very dependent on the higher life expectancy. The effects on earnings are much smaller. And so that's going to be an important thing to track, as these guys are still pretty young. And we fundamentally don't know whether or not, the higher rates of survival are just moving things by a couple of years or moving them for a longer period of time. And ultimately, we just can't say as of yet. And it's clearly very important. As for the denominator, we end up with the net cost to the government of $1. And so there's both positive and negative elements in there. There's the cost of the dollar of food stamps, the direct cost. And then there's the effect that occurs through the labor supply distortion. So we need to net that out. And that's 16 cents on the dollar. And so that gets us to the cost of the food stamps, which is $1.16 gross of the distortion. And then we've got the fiscal externalities that lower that in the long run, which occur through the reduced incarceration, which generates 9 cents on the dollar, and the increased tax revenue from the higher earnings, which generates 7 cents on the dollar. So you put that all together, and that's where you get the marginal value of public funds of 56. So just to conclude, food stamps is a central element of the social safety net, and we provide sort of comprehensive, large-scale evidence that shows that providing food stamps, particularly to young children, or families with young children, has large long-term benefits, both for the children as well as for society more broadly. And generally speaking, the earlier the exposure to food stamps, the larger the impacts of the program. And this, is quite a high return on investment that we typically have not talked about with respect to the social safety net. And this is something I've been thinking a lot about as we sort of watch the rollout of the one-year child tax credit and the increased resources for low-income families and what that might generate in the long run. So thank you.
Thank you. All right. So folks should feel free to post your questions in the chat, but we have a quiet set of folks, so I'll go ahead and take the liberty of the first question. And I'm going to ask an unfair question. And I think it's unfair because I think one of the things I really love about the paper is you went and got just an enormous amount of data to bring to this question. And so I'm going to think about additional data to bring to the question. And I'm curious really about potentially getting cause of death data, NDI records merged in to see if there's sort of differential cause of death for those that were exposed to food stamps earlier in life versus not. I know it's my understanding is that it's expensive, but is potentially doable in the RDC environment. I was wondering if you thought about it.
So I guess the first thing I would say is there'd be so much value to that, because sort of one thing I didn't talk about in the talk is trying to understand, like, where do these estimates come from? Is this like a biological channel? Is this a poverty stress channel? And the impacts on kids? And I think there's definitely a lot more we could learn from that. One of the things that we talked about doing, and maybe Martha might be able to say more about this because I should say, Martha is the one that spearheaded the merging of these data together. One of the things that we really wanted to look at was, is this gain in life expectancy something that results from less death in younger years or less death in older years? Is it looked to be things that might have to do with like some of the work that's been done on Medicaid and, teenage reductions in mortality, or is it something that might be more related to kind of like conventional heart disease and things like that later? And that was not available to us. The date of death, using the date of death was not available to our project. And I don't know if Martha knows more about the cause of death data.
Mute. Can you hear me?
We
Yep.
can.
Yeah, so there are a couple of things about the new Medit. One of them is that the death reports are highly incomplete sort of before the modern period. So you lose a lot of the early deaths for these cohorts, which means that it's really hard to document sort of child mortality and those types of things that you'd want to really see. So we really can't do that very well in the data. I think you pay per record for the merge, Nate, is that right? Yeah, and those big sample sizes that Hilary was talking about at the beginning, I don't know, this might be the kind of money you can raise, but maybe out of reach for the for others of us.
Yeah, no, it feels like this is the kind of thing where, boy, you wish that this was a freely available set of.
It's not clear to me. You may know this if whether or not in the Census Bureau they're working on doing this kind of at a broader level for multiple projects. I can imagine there's a lot of value in this, not just for our project, but for a whole lot of research projects. So if that were the case, I want to echo Hilary. It would be enormously valuable for this project and a lot of others.
I think that, when they get to be Medicare age, there's going to be a whole nother set of data that we'll be able to universally have for this population that I think could also be really valuable. And, we're not that far away from the beginning of that, but it's going to be another 10 years, I think, until there's enough there. But that's the other thing that, has been sort of in the back of my mind is like where there could be a lot of gains to, like replicating the small sample findings we had about metabolic health in a setting where everybody's insured and we've got much better data. So that I think could be very helpful to try to understand the mechanisms.
That makes sense. And so I'll ask my other favorite question on this. One is about kind of the age of the effects and really thinking about, you're focused on kind of the 0 to 5 and finding kind of smaller effects at the older ages. And I know, what's nice kind of about the way you approach it, you pre-specified that was sort of the focus here. But I'm curious kind of how, we want to think about this particular mechanism through which food stamps is affecting, like I could have imagined another set of channels operating for 5 to 10 to 15-year-olds. There's the literature thinking about providing cash to parents at the time their kids are thinking about going to college is having effects. And just trying to think about how the different age effects kind of are operating there and kind of what drives the strong focus on the 0 to 5 kind of a priori or kind of motivated by kind of what other evidence you're bringing to the table. Just curious how you thought about that.
Yeah, thought about it a lot. I guess the first thing I would say is the nature of these rollout kind of designs is that policies never turn off. And so, once it's just important to sort of think about what if someone is exposed to 3, in our world, they never stop being exposed. So we don't, we observe people who are exposed later and not earlier, but we don't observe people who are exposed earlier and not later. Mm-hmm. That's just not, we don't have that in the nature of our treatment. So that's just like something to kind of file in the back of thinking about what this program, how we can think about it. I would say when I first started working on this, it was very much thinking about the importance of food stamps as a nutrition program, even though it is pretty fungible. And the kind of, the well-established evidence that sort of, certainly in utero, reduction in nutrition quantity and quality lead to long run impacts. And there was a bit less about sort of post-birth. And so it seemed like a natural hypothesis that you'd have longer term impacts for earlier life exposure that sort of came from that setting. But, at the same time, we know that this doesn't lead to just increases in food. We know that from the work on spending. So that's a little bit too narrow, I think, of a lens of thinking about what the program does. But it's, it's like we've got the MTO evidence that seems to show earlier matters. I know it's a very different program, but then there's the EITC evidence that shows that it seems to matter more later. And so it's not, I don't know, it's not clear to me, I think. I don't think it's universally earlier in childhood across the kind of a broad thinking of the social safety net.
Yeah, that makes sense. All right. Looks like we have one question in the Q&A. People thinking about claims data merging in on prescription drugs. I know you mentioned the age 65 plus, which will be awesome to think about incorporating data from Medicare, and presumably incorporate perhaps the Part B information to see what they're on. But it would be interesting. I mean, we can go beyond the government data if you can get private prescription drug data.
I don't know. Amy might know that. Is any of that in the RDC? I didn't, or maybe Maya would know that from some of the work that she's been doing. I know mostly in Scandinavia, but
I don't
think so. But there's, that is there. Like that is something that would be very
Medicaid claims data are starting to be available. But for our purposes, I think that would be challenging, given that we find that there could be an effect on the likelihood that you're on Medicaid, right? And so, I'm not familiar with anybody who's been able to merge in private insurance data in there.
That makes sense. All right. Well, thanks for the wonderful paper.
Thank you very much.
You see that?
We can.
Awesome. Okay. Well, thanks so much, Nate, for inviting me. I'll move pretty quick. It's been a long day, I'm sure, for the panelists. I'm very happy to be able to contribute to this, and hopefully I did my MVPF homework correctly, so you can grade me on that. And I'll also give just a quick shout out to Yoram Meshar, who is an old friend of mine and was my colleague at Hebrew University and is the originator of some of the ideas in this work, meaning the MVPF idea, as Nate and Ben know. So the program I'm talking about is financial aid, post-secondary aid. I don't think I have to motivate that, so I'll just skip right to the program. I think it's pretty clear the context why we're interested in offering financial aid to college students, particularly lower income and disadvantaged students. So the program that we're studying in this paper, and let me mention my co-authors as well, David Autor, who's with me online here, and Mandy Palace. The program we've been studying actually for 10 years. So it's our longest, it's probably the longest running research project I've ever been involved with. Is a financial aid program run by the Susan Thompson Buffett Foundation, and they distribute about $40 million a year to 4,000 public college students. That's 11% of not just University of Nebraska, but Nebraska public schools. So it's very large in the context of Nebraska. And we've had the opportunity to evaluate it in a randomized trial, and we think that's very relevant and interesting evidence, and it's relevant for public programs as well. So when we do the MVPF thing, of course, it's not a public program, but we could think about it like that. Let me give you some background on the structure. The applicants are screened partly on the basis of a target campus that becomes a stratum for randomization. So they might identify that they want to go to the University of Nebraska, which is the research university in the system. They want to go to the University of Nebraska campus at Lincoln. That's called UNL. Generally, and I'll use these acronyms throughout the talk, University of Nebraska campuses are called NU. So you have to remember that. But the University of Nebraska at Lincoln is called UNL, and the University of Nebraska at Omaha is called UNO. There's an element of non-money intervention as well. So applicants who end up at an NU campus participate in a program called Learning Communities, which is a widely used intervention with post-secondary students, trying to keep them on track, earning their credits and in good standing and so on. We were interested in the value of that part of the program, so we came up with a scheme where some students are offered aid only, and others are offered this package of aid plus learning communities. And we call the aid only intervention the College Opportunity Scholarship. That's the way it was kind of branded for the applicants. So I'll also distinguish two treatment effects down the road. Who is potentially eligible for this aid? So any Nebraska resident high school senior or graduate of Nebraska high school with a GPA above 2.5 and an EFC, as computed on the FAFSA below $10,000. Initially it was a little higher. And the way the applicants are screened, they're evaluated by both merit and need. The merit criteria are similar to sort of low bar state merit programs like Georgia Hope and Massachusetts Adams Scholarship. So we think our evidence is especially relevant for thinking about the likely impact of those kind of proliferating state aid programs for students at public colleges and universities. How big are the awards? The awards are quite large. They cover tuition, fees, anything up to the federally recognized cost of attendance. So it's meant to really allow you to go to college with nothing paid out of pocket. They're renewable for up to 5 years if you're in a 4-year degree program, for up to 3 years if you're in a community college. There is some conditioning on having an adequate GPA, though you would need to have an adequate GPA to stay enrolled in any case. This is more generous than state merit aid, so you could think of it as kind of an upper bound of those sorts of programs. Now, we had a challenge here to design this program. So sort of like building an airplane while it's flying. The program is running, but we want to not disrupt the program too much, but we need to get in there and inject an element of random assignment. So the way that this worked out is applicants are scored in various ways, and then there's a univariate score, and some applicants with very low scores are not offered scholarship, and that they're not going to be eligible no matter what. And some applicants with very high scores on that measure are surely funded. And then there's a large group in the middle that's subject to random assignment. And the size of that group changes with respect to the target campus and also over time. But we're allowed to get in there and have in the intermediate group randomization, not necessarily a coin toss in the sense of 50-50, but it's still a random assignment. Okay, so the target campuses are a key element of the design of this study because we analyze separately. We're interested in an analysis of 2-year programs, 4-year programs, and so on. So the application for the scholarship solicits information about the target campus. Students or applicants who say they're interested in 4-year degrees, we classify them on the basis of that. And then they may target University of Nebraska, one of those 3 campuses, or they may target the less selective state college system. They may target community colleges. Now, what happens is, if say you target University of Nebraska, you're either awarded, as I showed you, not awarded, or you're in the bubble. That means you're subject to random assignment. And then for the NU group, the group subject to random assignment may be offered the regular STBF award, which has long come with the learning communities component, or you may be getting aid only, or you may be getting control. People in these strata are only getting the regular award, but then that doesn't include learning communities anyway. Okay, so that's our research design, and that leads us also to a natural stratification scheme. When we look at subgroup effects, we look, for example, at people that say they want to go to the University of Nebraska at Omaha, which is the urban commuter campus, somewhat like, you can think of it as something like UMass Boston. Okay, so, and most of what I'll show you today is going to comes from data on the applicants who are targeting 4-year schools. So we have lots of good data on the program, on the applicants, and on their outcomes. We have the whole application process where we're collecting the same information that the program uses for admission. So high school transcripts, ACT scores, FAFSA reports. There's some survey information. We get some additional demographic information from the Nebraska Motor Vehicle Department. And then we have good post-secondary outcomes. So we have virtually complete follow-up because we either have the NSC or we have the schools themselves. So that's going to give us information on where you go and did you finish? And in some cases, we'll know your major. And also, if you did go to a Nebraska public school, we'll know what sort of financial aid you got in addition to the Buffett money. So what I'll show you today is some reduced form offer effects. What was the treatment effect? Fairly straightforward. And then I'll give an interesting story, what we think is an interesting story, where we have a kind of a very simple explanation for why the program works for some people in the sense of increasing the likelihood of getting a degree, and it doesn't have much effect on other people. So that's our early engagement hypothesis. And then, of course, we'll do the MVPF, okay? And that's the dangerous part for me. Okay, so here's some info on the applicant demographics. The key fact that might surprise you here is there's a fair number of minorities in the sample. So only 63% of eligible applicants are white. The largest non-white group consists of Hispanics. There's also some Black applicants. And then something else I want to draw your attention to, there's 11,000 eligible applicants from the point of view of the program rules. 8190 of those were subject to random assignment, and a little under 4,000 were actually offered scholarships. Now, in fact, I say offered, but offered is about the same thing as, using the scholarship, because the take-up rate is very high. So you might imagine we should use the offers as an instrument for whether I actually use the scholarship in the end, but most people who are offered aid accept the aid and they use it to fund their schooling. And we'll see that the initial enrollment rate is very high. This is a population that's very likely to start out in college with or without aid. So the basic framework is an offer effect. A indicates scholarship offers, and then we do need to control for the fact that the probability of being treated differs by these target school strata. So we're adjusting that in simple regression models. And I should also mention that the degree data are not available for all the cohorts. So there were 5 cohorts in the experiment, but the degree data, which I'm focusing on today, are only available for 3 of the cohorts. And only 2 of those have the COS treatment. COA should be COS treatment, meaning the treatment at NU without learning communities. Okay, so let's see. The first fact is, how much did we affect financial aid packages? Those of you that are aware of, the way financial aid works in PhD programs, you might wonder, if you get outside financial aid, does that actually improve your funding? Because we see how that works inside our own program. So in fact, this program is not really taxed away. So the total STBF aid received in the treatment group is about $8,000 in the first year. That doesn't increase the financial aid package dollar for dollar. So this is treatment, this is control in the gray, and you can read the difference there in the bar height, and that's adjusted for strata. So that's like control plus the treatment effect. So you can see you don't get as many dollars of total aid as were awarded, but you do get about 1-for-1 in terms of grants. So what happens is awarded students are getting more generous packages, but they're also reducing their loans and work study. So that's about half of what happens. So they're going to finish school with less debt, and that's something that's interesting as well to study, and we're eventually going to be looking into that, but I don't have any results on that today. Okay, so here's the first kind of impact. How did this affect my initial enrollment? So as I mentioned, this is a group that's very likely to go to college. So 96% of the control group does go to college, at least they start, okay? And then the treatment effect is only a couple of points, 2 or 3 points. And that doesn't differ very much according to whether it's regular or COS, but that's as it should be because the learning communities thing comes later, okay? And then here's where there is an interesting difference, okay, is there is a notable shift to 4-year programs. So enrolling in a 4-year program, 83% of the control group does that, but the treatment, getting an award boosts that by about 11 points. So that's interesting. And some of that is a reduction in 2-year enrollment, and some of it is just new enrollment. And then there's also an increase in the likelihood of going to a Nebraska public school. and some reduction, modest reduction in going to school out of state. Okay, but a big reduction in going to community college. So generous funding for four-year programs moves a fair number of people, though by no means most. So it's a substantial treatment effect, but most of the control is doing this. Okay, but then there is a substantial treatment effect of 11 points. I'm going to skip ahead now to the degree effects. There's other results in the paper for those that are interested. Sorry. This is the slide I want to skip to. So here are the degree effects. This is just a dummy for did you get a BA 6 years after random assignment. So it's conventional in this kind of research to look at 6-year completion rates. So even though these are so-called four-year programs, again, they're sort of like our PhD program. They take 6 years to finish the four-year program. The median time to completion is about 6 years. So the award of the control mean on that 64. So 64% of the controls got a BA. Now here I'm only looking in that four-year stratum. So I'm throwing away the people who said they want to go to 2-year. And I'll just mention parenthetically that there isn't a huge effect on the 2 years at all. So 2 years, 2-year targeters did get substantial financial aid, but the awards did not redirect their educational plans by very much. It's not a significant effect. So it's not, doesn't rise to there's a slight diversion into 4-year or shift into 4-year, but it's not significantly different from 0. Maybe later it will be. So we're here for the people who said they want to get a 4-year degree. The award effect is 8.1 points. So that's substantial. Though again, a lot of these people were going to get degrees. And you can see that in the fact that 64% of the controls get degrees. So the money is going to people who are affected by it, but most of the money is going to people, who are doing what they're doing, and the money is really just a transfer to them. And that's going to come out when we do the cost benefit analysis. It makes the program fairly expensive. And then we're interested in the difference between these two. So these are people who said they wanted to go to NU. If we just give them the same amount of money, it generates almost the same degree gain if you don't include that services thing. So that's an interesting finding that's relevant for people interested in academic support services, post-secondary academic support services. And then you could see where are these degrees coming from. So there's a fair reduction in associate's degrees, which is consistent with what I showed you on the initial. But there's also a lot of people who wouldn't have gotten any degree, and now they're getting degrees. Okay, so you can see that all adds up there. Okay, so how big is it? It's a 13%. The 8.1 percentage points is 13%. Okay, now here's something that's relevant for what's going to come later. This is by target campus within the 4-year strata. So the target campuses within the 4-year strata are the 3 campuses of NU, Lincoln, Omaha, and Kearney, and then a group of state colleges, which we're not breaking out. And one thing you could see, so this is the 6-year treatment effect with the whiskers showing the confidence interval. You could see that people who said they wanted to go to Omaha, University of Nebraska, Omaha, UNO, that is the group where the treatment effect is really noticeably larger than other groups. There is an effect on the group that said they want to go to Kearney and the group that said they want to go to Lincoln. Not so much the state college group, though part of that is imprecision, but it's also smaller. So there's something interesting there and maybe special, we want to get to the bottom of it, about people who said they want to go to UNO. Why does that group particularly benefit from these awards? Okay, so I already gave you the 2-second summary of 2-year effects. Let me skip ahead to the 4-year subgroups. Okay, and the 4-year subgroups are broken down in a number of ways, okay, that are guided by our understanding of how the program works and guided to some extent by, so I have to admit, some of this is guided by things that we learned, not in the pre-analysis plan. But some of it is conditional on our strata. Okay, so one of the first things that we looked at that's interesting and quite a dramatic difference is if you live in Omaha, so what I'm showing you here, just to orient everybody, this is the control degree completion line, 4, 5, 6, and then we have fall and spring. I'm really just going to go right to the 6. Okay. But you do see some evolution over time. And then this is the control plus treatment effect. And this is the value of the treatment effect, and then the whiskers give the confidence interval. But these effects are large enough and precise enough that usually the precision is not a big deal. Okay, so what you see here is 6 years out, people who live in Omaha, the treatment effect on them, and they actually have quite a low base, under 50% in the control group. That's a large effect. And people who live outside of Omaha, that's significant, but it's not, it's less than half as large. Okay, and that is consistent with what I showed you earlier a moment ago, that people targeting UNO also have a large gain. So it's not a perfect one-to-one living in Omaha and targeting UNO, but clearly that's correlated. Another thing, another interesting difference is there's somewhat larger effects among non-whites, a third of the sample relative to whites, 2/3 of the sample. It's not dramatic, but it's there. Very little difference by gender. And then looking at measures of family background, so we know whether your family is poor enough to qualify for Pell, and bigger effects among the Pell eligible, 9 points versus 6. And bigger effects among first generation, 9 points versus 5. People who are first generation. So for us, we're defining that you're first generation college if you have no parent with a BA. Okay, so that's all kind of interesting and suggests the program is more effective among lower income disadvantaged folks and people who live in Omaha, which overlaps with the non-white population and poor minorities as well. Here's something that's a little bit more in the weeds. Some of the, so we collected data on the target, and then we said, well, what would you do, if you got the money? So that's the target. And what would you do if you don't get the money? So that's your fallback or your kind of your second choice. And some people said they would go to community college, and some people said they would go to another four-year program. So maybe my target is UNL and my fallback is UNO, but maybe my target is UNO and my fallback is community college. Okay, so if your alternative is a 2-year school, there's also a very large effect on that group. And it's almost double the effect on people who have not listed community college as a fallback school when they're not awarded. So it's interesting to have that data, and I'm going to use that data in a second to explain what I think is going on here. Finally, there's another set of results that are thought-provoking, I think. We call this the paradox of merit aid. The program evaluates both for merit and need. Of course, the more meritorious have higher GPAs in high school and they have higher ACT scores. And that's perfectly anti-predictive of impact. So the better your ACT scores, the less the program produces degrees for you, okay? And if you have below median, meaning below the Nebraska median ACT score, that's a very large impact. So people with low test scores benefit from the program more, and people with low high school GPAs, and this is below the median in our data, there's a 12-point degree gain for that group versus 4 points for people who have high school GPAs. So that's the paradox of merit aid. The meritorious are likely to go to college and get degrees anyway. Now, of course, it is problematic to think about program design, right? You wouldn't necessarily want to create a program which says, we're going to give money to people with low ACT scores. So there's an issue there. But we have a story that kind of rationalizes all of these facts. And the story goes like this, okay? And maybe also suggests some things that you could do which would be more palatable than specifically designing an anti-meritocratic program. So why, let me take an example to kind of explain it. Why UNO? Well, basically, the group that targets UNO, they're least likely to end up in a 4-year degree program in the absence of aid. And it turns out that that is kind of a theme, and that's true for all of our subgroups. So why low ACT? The groups with the largest BA impact are fairly consistently people who have a rare 4-year enrollment counterfactual, meaning they're not likely to end up in a 4-year program in the absence of a degree. Now, there's actually kind of 2 parts to that, and I'm skipping the details in the interest of time today. But one is, for whom is the award consequential from the point of view of their target school? So for the award to have an impact, it moves me into my target campus. If I go to my target campus anyway, maybe the award doesn't have an impact. So it turns out that impact is correlated with what we call target compliance. So I said I want to go to UNO. Does the award actually enable me to do that? And then there's a well-defined population of compliers in that, based on that endogenous variable, a late style compliers. And the counterfactual is relevant for those folks. I'm compliant, I go to my target. I don't go to my target if I don't get funded. Where do I go? Do I go to a four-year school or not? Okay. And that all adds up to the likelihood of having a four-year counterfactual for my initial enrollment. So we put these pieces together and came up with a very simple, you might say, reductionist view of what this program does and how it creates degrees. And it might be relevant in other programs like this. The hypothesis that we ended up evaluating is that the primary channel for aid-induced degree gains is strong initial engagement with a four-year program. And we'll go out on a limb here in the spirit of a strong exclusion restriction and say that aid works exclusively through this initial four-year channel, with no effect on those who would otherwise go full on 4 years. So if you were going to start out in a four-year program and be a well-engaged freshman and taking lots of credits and finishing those credits, it doesn't much matter that you got aid. So we're going to not find support. We don't find support for the idea, for example, that having aid is going to insure me against family financial shocks or something like that down the road, or that there's a large incentive component to keep my credits up. Okay, it really seems to operate through this one channel, which happens very early. Now, I may need to promise you a very generous package. I may need to promise you full funding for your entire college career. But once I promise you that, if that succeeds in getting you to engage fully with the four-year program, I know everything I need to know. So we explore this hypothesis and test it with a visual instrumental variable strategy. It is testable, just like any exclusion restriction, when you have lots of instruments and lots of groups to look at. So basically we're saying this early engagement channel rationalizes all the reduced form effects, including the ones I showed you earlier and some more. So it rationalizes Omaha versus Lincoln targeters. It rationalizes low ACT versus high ACT. It explains everything about program heterogeneity, about heterogeneous impacts, in particular by strata and subgroups. So here's a schematic of it, though this is actual data. The way we substantiate it is we say, here's the first stage effect on this mediator. The mediator is initial four-year credits earned, okay? And the outcome is my BAs. So that's the reduced form. And that's the first stage, okay? And here's two data points. UNO, there's a big effect, as I explained earlier, there's a big effect on UNO targeters, actually getting them into a four-year program. So people said they want to go to UNO. In the absence of an award, the probability of starting in some four-year program falls quite a bit, okay? And sure enough, they have a pretty big reduced form. People who said they want to go to UNL, there's not much of a first stage effect because that's a group that's likely to go to a four-year program anyway, with or without aid. That's the more selective of the NU campuses. And so those 2 points, you know, they fit our hypothesis perfectly. They fall on this line, which attributes all of the reduced form variation to first stage variation, but that's a pretty low bar with only 2 points. So let's see how it fits when we do all of the subgroups that we examine in the paper, which is quite a few. So that turns out to fit well. Same first stage, same reduced form. The first stage, I should mention, is measured as the share of full enrollment, so the share of a full credit load. So it's your credits earned on a four-year campus in your first year divided by 24, which is the threshold that you need to be considered full-time, to be considered a full-time student. And it turns out that, you know, the data points of interest to us, the groups of interest to us, here's UNO way up here. Here are people that said they want to go to a two-year program way down here. Here's the low ACT group, they're over there. Here's the UNL group, they're down. Okay, so this one kind of mediation story seems to account for all of the variation that we've explored in the paper. So that's kind of impressive. And now you could say, well, does that actually fit the line? Because the points, of course, are not exactly on the line. You could see there's some whiskers there showing the sampling variance. So the way to test that is, two-stage least squares over identification. This is an over-identified model. There's a single endogenous variable, and the instruments are the offer effects interacted with strata and subgroup. And it turns out to fit very nicely. And we do that in a bunch of different ways. And we show that that's coherent and consistent. The slope of the line is 0.6, which means, take the proportion of the fraction of a full-time load that you're engaged with in the first year and multiply that times 0.6, and you'll know the degree effect on that group. And, this is the part that's nice and simple. That's really all you need to know about a subgroup to predict the program effect on that group. So if you want to look for groups where you're going to really make a mark on degree completion, you need to look for people who aren't likely to complete the first year of a 4-year program successfully. Okay, so there's a lot more on that on the paper. There's some stuff about how it plays out over time. But let me skip to the heart of the matter for today's agenda, and that's our cost-benefit analysis. So, ultimately, I should mention we'll eventually, measure the earnings of the treated control group, and we'll be able to tell you how much more the treated earn. We presume that there's a return to this schooling, so I don't want to prejudge, but is likely to earn more. They're likely to earn more. But for now, we can impute the future earnings, and then we, based on what we think about the returns to schooling in random samples and including samples from Nebraska. And then, of course, the costs are reasonably well measured. So there's two types of costs here. There's the funder cost in the treated group in the 4-year strata, which is what I'm focusing on today. Per treated observation, the funder is spending about $34,000 all told. Okay, you can see why the program is expensive, because $34,000 per treated observation only got me 0.08 of a degree. So that is a pretty expensive public university degree. Even so, labor economists think the returns to college are quite high. So it's not clear that it doesn't pass a CBA. Now, anyway, and it took me a long time to understand this. I have to say, David and Mandy explained this to me 100 times. That's just a transfer. And the social cost, because I didn't really take PF in graduate school. So the social cost of the program is the extra, in a very narrow sense still. The social cost is the extra educational spending. So in the control group, the cost of attendance for students there is about $30,000, $31,000. And then COA goes up. There is more spending on school. And here I don't count, the transfer. I just count the fact that people are going to school longer, and that costs money. Okay, so, and we're not worrying too much about the details. We're just taking the cost of attendance as recorded by the federal government for the amount of schooling that they have. So you might say, well, we could do better on that. Okay. Anyway, those are the costs. Okay, so we have two ways of benchmarking the costs. We have the funder cost, which is quite high, and we have the social spending on education, which increases, but not very much. Right, it increases from 31 to 33. Okay, so now I have what I need. Oops, wrong. My links are busted there. Sorry. So now I have what I need to do. No, I don't have everything. So the other thing is, how much do earnings go up by virtue of the extra schooling? So this is our imputation. And as I mentioned, later we'll do better on this and really measure this. But for now, we compute the PDV of the earnings gain that you would expect from the amount that schooling is going up. And that's going to depend, of course, on the discount rate. So with a low discount rate of 3%, though I think this is used in Hendren and Sprung-Keyser. So that's why we did that. The earnings gain is 23,000 overall. You do see some interesting differences by sex and race. Minority men have a particularly large gain. If you discount at 5%, the gains are not nearly so large. Anyway, that's what that is. Okay, now we can do the MVPF. Okay, so the MVPF goes like this. the ratio of private benefits to public costs. So F is the transfer, so that's 34,000. G is the award-induced gains in the PDV of earnings. That's 23,000 roughly. And let's say the tax rate is 0.2, and that's going to be applied to the G. Okay, so the MVPF ratio is the same formula that you've been seeing all day. We get to put the F both in the top and the bottom. And then the G is 1 minus the tax, the gain is 1 minus the tax rate. And then the government gets to take some of the taxes. Now, when I say the government, I mean the Buffett Foundation, which isn't the government, but we think of it as kind of a model of, a public program. Okay, and maybe something like Georgia Hope. Okay, so if you put the numbers together, the 34 and then the 23 and then the taxes, you get an MVPF of about 1.8. I should say we're messing around with this somewhat. The earnings imputation is a little tricky. So this is maybe not the last word, but it's ballpark about what we're going to be reporting in the paper. So that says that $1 of public spending on this program generates $1.77 of private benefits. So that's substantial. We could compare it to some other MVPFs in the Hendren and Sprung-Keyser paper. In that paper, Nate and Ben reported it's not a less than 1 MVPF for the Massachusetts Adams Scholarship. That's a little bit of an unusual program. So a nice paper by Sarah Hoynes and Josh Goodman that the Massachusetts Adams Scholarship seems to actually reduce degree completion. And there's an interesting story there and again, it's about the counterfactual. What do I do in the condition when I'm not awarded? It seems like it diverts people into public university campuses where completion rates are lower than they were in the counterfactual condition of mostly private schools that seem to have more success in getting their students through. So that one's easy to beat. But the Wisconsin Scholars Program, that's a little bit like ours in that there was a randomized evaluation of that done by Doug Harris and co-authors, and that has an MVPF of 1.43, according to Nate and Ben. So that's interesting how that comes out. We seem to be doing pretty well as far as MVPF. I think the calculation here, we had a lot of interesting discussion in the group, and I'll just throw some questions out there for the MVPF mavens. One of the paradoxical things to my mind is that the MVPF loves high taxes. So the more taxes, the better. And if we were to tax it all, we could have an MVPF greater than 3. And that doesn't really seem like the right answer to the question about how this program could be designed. Now, I know Nate will say, well, you're supposed to just put all that aside and you're just comparing the programs and the tax regime is whatever it is. But there is this implication. And you might think, for example, that the G is sensitive to the T, so that if I really raise the tax to 100%, I wouldn't get any G, for example, and that would change the calculus. The other thing that I find a little puzzling is, it's true that more schooling yields higher wages, but that's not necessarily my valuation of the schooling. If I'm choosing schooling optimally, and this is actually in a footnote of the paper, if I'm choosing schooling optimally, the gains here are not the earnings gains. And, so the envelope theorem cuts both ways. Maybe there aren't really any gains when you allow for the fact that I have some disutility of schooling or that schooling is a pain in the ass. So that is also, now that I think, is just sort of asserted in the framework that we're going, from the point of view of the schooling, we're going to ignore the possibility that schooling is optimal. So it seems like to have a full welfare analysis, you still need to tell me why people aren't getting the right amount of schooling if you really think it's not optimal. Okay, so I think I probably should stop there and happy to discuss.
Thank you, Josh. Yeah, this is absolutely wonderful. It's exciting to see the MVPF calculation of the program there. And the questions you raise, I think, are spot on, right? I mean, the MVPF is certainly sensitive to the tax rate because the fiscal externality is sensitive to the tax rate. just kind of think of that as a reality of the world. But totally agree, it relates to Chris's work finding potentially lower MVPFs of human capital investments in India because the tax rate's naturally lower. And I think that's a kind of a reality of this kind of unidimensional, we're studying one program at a time, but there might be two programs at once that might do better than one program at a time, where you're simultaneously adjusting the tax rate. I think that's something that's important certainly to keep in mind. So we have gone over time, and I can't thank everybody enough for joining and for presenting today. This marks the end of the presentations that we had scheduled. Ben and I are happy to stick around. We were going to talk a little bit about the Early Career Scholars Grant that's available to untenured faculty and graduate students. We'll go ahead and put up a slide referencing that. But while we do this, I just want to thank all the panelists for coming, and everybody should feel free to go on their merry way. And we really look forward to keeping in touch with everybody. But this Early Career Scholars Grant is something we're really excited about. To any graduate student or untenured faculty, if you are interested in constructing an MVPF in your work, we're able to offer funding of up to $20,000 for faculty, $10,000 for graduate students. The application materials are all available on the website, and we're happy to answer any questions to folks that are around and would like to stick around and chat about it. But for now, I just want to end with a heartfelt thanks to everybody, and really look forward to continuing this discussion with folks. And hopefully we'll see many of you next year. So thank you very much.